So I'd like to start this session by thanking all our supporters and recognizing our major sponsor, the Social Planning and Research Council of BC, which is a leader in applied social research, social policy analysis, and community development approaches to social justice. Lorraine and her great team support the Council's 16,000 members and work with communities to help build a just and healthy society for all. Unending thanks for supporting the summit and the podcast. I'd also like to acknowledge again that while you're joining us from across Canada and beyond, Heads Up originates on the unceded territory of the Syilx people in the Okanagan region of British Columbia. And before we get started with our kickoff keynote for this session, I'd like to introduce Laura Elliott and acknowledge her family to whom this session is dedicated. Given that this session will help us find integrated solutions for substance use and homelessness, I asked Laura to share the story of her brother David, who died in 2019 due to liver failure caused by alcoholism. So welcome, Laura. I so appreciate you being here. I know it's not easy talking about what your family went through. So thankful to have you here, Laura.
Thanks so much, Joanne.
So first off, tell us about David.
He was just a couple weeks older than 40 years old. When he passed away, he was a life of the party kind of a guy, always having a good time, always wanted other people to laugh and just enjoy themselves, take life easy. He's just a fun-loving person.
So you mentioned when we spoke earlier that you think David's mental health challenges and ultimately his addiction began in childhood when you said his free spirit butted heads with inflexible teachers at a very conservative school. So can you tell us more about that kind of trauma and how it affected him?
For sure. I think sometimes when people think of trauma, they think of it as like one big incident that sort of changes life forever. And it is that sometimes. For my brother, it was, he was involved in a school, as I was, where you were praised for being very type A, quiet, studious, always following the rules, not rocking the boat. And that's just not the kind of guy that he was. So he was daily ridiculed by staff members, teachers, for not conforming to what they felt he should conform to, and then sort of held up as an example for the other kids of how not to behave. So the message that went in for him on a daily basis, all through elementary and quite a bit of middle school, was that he was bad. Not just that his behavior was not desirable, but that who he was bad and not deserving of success or love or friendship.
And you mentioned that when he moved into middle school and high school, that he found solace with a group of kids who maybe weren't the best influence on him.
Yes, that's true. My brother had a lot of love to give. He's always a very loving person. And so he would seek out other people that had been labeled the bad kids, to be their friend, to meet them where they were at and be a part of their lives, and then show them friendship and love that he felt he hadn't been receiving consistently from the people around him. And it just turns out that the kids that were labeled as the bad ones were also the ones that were into a lot of drinking and drugs and those kinds of things.
Now, I know he started doing drugs and alcohol when he was a teenager, but when you realized David's conditions was serious, what did your family do?
I can't quite remember like the conversations that sort of surrounded it. It sort of felt like we knew he had been spiraling out of control emotionally for a little while, that he sort of had a rough crowd, but it was sort of like a slow seeping into, oh, I think there's something really happening. For me, the most significant memory was I was in my mid-20s, I would say, and I was in Toronto for a teacher training conference, and he was living in Toronto at the time. And so we got together to kind of catch up and hang out, and he was completely drunk by the time we got together, like, 2 o'clock on a Tuesday, and had a big, 2-liter bottle of alcohol that he was just drinking the whole time that we were together. And for me, that was sort of the big, like, oh, like, this is a thing, like, this is something that's going on in your life that's much bigger than I thought it was. And so we had some conversations as a family, just like how he was doing and things that were happening in his life. And eventually it sort of led to a point where my parents had convinced him to move back home to Kelowna so that he could be closer to the family.
So in that early time, did you get the support you needed from the mental health care system?
There was a lot of there's a lot of information. So, here's the list of places you can go for rehab. Here's a support group. Here's this, here's that. And so there was a lot of good information, but not a lot of information about how to help David navigate that. Lots of stuff for us as a family, but helping him access the support that he needed was a really difficult process.
Ah. So how did David's illness and ultimately his death affect you and your family?
The illness was hard because when someone's an addict, they're not themselves, and so there's a grieving process. While you grieve the person that not being there all the time, like in snatches, but not really consistently. And so it's hard as a family to walk through that because you're all grieving together and that person is standing in front of you, but you're grieving that person that's standing in front of you. And it's a very odd experience.
So how are you personally experiencing grief at this time?
I'm not sure. We have a long history of mental illness and substance abuse issues in our family. And so it feels like we've been in a survival pattern for a long time.
Mm.
No, we really, really grieve the loss of my brother a lot. There's a lot of other things going on. And so it feels like trying to grieve David when you're already depleted because you're trying to work through everything else.
You talked about the importance of the relationships you had with people outside of your family. Can you tell us about those?
Yes, those were critical for us. The support that we got from friends that were outside of our family that knew us and cared for us, but weren't as emotionally invested in exactly what was happening were critical because the hardest thing for us is walking that line between helping David and enabling David. And to have those outside people that you trust that can say to you, are you sure you want to do this? Will this actually help David or will it enable the behavior? Like just to have those hard conversations with us was so helpful.
You also talked about people helping you to be less enabling. Can you tell us more about that?
Yeah, I think it's so hard when it's your family to say no. You really want to, even if everything in your head is telling you you have to set a boundary, you have to say no. It's very, very difficult and much harder than you think it's going to be. So it's incredibly important to have people that can say no for you when you can't say no.
Laura, I can see how difficult it is for you to be vulnerable and to share this story. Why did you feel it was important to do this?
I think it helps me wrap my head around it so selfishly to help myself, and also because I think that it's the personal stories that enable other people to do what they do professionally, working in these industries that deal with mental illness and with addiction. To have those personal stories gives you a face for all the names of the things that people have, and also for other people who have family members that struggle with mental health or addiction issues, or people that struggle with those things themselves, to know that it's a lot of families and it's a lot of people, and it's not just you, and you're not on your own. And there's lots of us out there.
If you could say one thing to our viewers about what you've learned and how they can help, what would that be?
Well, good question. I would say to just, I know everybody says it, but just keep talking about it. Keep asking the questions. Talk to your friends, talk to your family members. Create safe space for people just to say where they're at. You don't have to have the answers. You don't have to fix it for them, but just having a space where people can talk gets it out. And then it's not so shameful, because shame and secrecy just bury it even more. And it's harder for people to get the help they need.
Oh, thank you so much, Laura. I am so inspired by your courage and your candor, and I'm sure that the viewers are as well. So thank you again.
Thanks so much, John.
My expert co-facilitator for our next session, which again is called Finding Integrated Solutions for Substance Use and Homelessness, is Lawrence East, a community mental health advocate in Kelowna, BC, who has seen the effects of stigma on street people throughout the world. In response, he's worked with nonprofit organizations, social enterprises, and financial literacy and impact investment advisory groups. He also founded Metro Community, a street-level church and social agency in Kelowna, where he served as lead pastor and executive director for 12 years. Lawrence regularly shares his insights and passions as an adjunct professor in the Faculty of Management at UBC and a guest lecturer at Okanagan College. Lawrence, welcome. Thank you for being here.
Thank you.
You've been working with and for people with substance use and housing challenges for decades. How have you seen these challenges change or evolve over the years?
Well, some haven't changed at all, sadly. There are some consistent challenges that pervasively exist throughout time. We'll be talking about stigma today. There are some stigmas and some pieces of human conduct, I think, that just, and prejudices that follow us and haven't evolved, and they haven't always found a more mature or a more evolved way of thinking. I just wanted to say, I don't know if Laura's still listening, but I'm just so moved by her story and her courage. And, I think one of the things she mentioned was shame. I think that there is from the standpoint of the general public, there is a willingness to sort of dehumanize somebody that we do not understand. And the way to do that is to clump them into groups, to depersonalize them. So make sure they don't have a name, don't have a story. We don't want to think about them as having parents, brothers, sisters, because as soon as we do that, we imagine what it would be like to have our son, our daughter, our brother, our sister in that situation. And that causes us to engage a level of compassion that we aren't necessarily always comfortable engaging in. So it's the more distant we can create that sort of dehumanized, sort of stigma, then the better. And unfortunately, that hasn't changed too much. I would say the other thing that hasn't really changed over time has been some of the sort of the power dynamics that exist between those who are caught in a struggle with homelessness, mental health challenges, addiction, and so on, those who are living in a very vulnerable state, and those who are decision makers over them, so to speak. Brené Brown talks about the different forms of power: power to, power over, power with. And so often in this field, there is a remarkable leaning towards power over. And we've got to be so careful about that. There is some change. Like, there are some places in the world, and certainly in our own backyard, where we're beginning to see a move away from siloed ways of trying to deal with challenges and issues that vulnerable people face. And now, as your conference suggests, integrated solutions, which are, to my mind, the only way forward, because we have seen that these individual sort of approaches don't work on their own. And so, yeah, an integrated approach is always much more successful. So there is a little bit of a shift, I think, but there are some age-old pieces that have not changed.
All right. Well, we're going to kick off this session with a presentation by a fellow named Guy Felicella. He spent years in the grips of addiction, almost a dozen times from overdoses. And Guy's current passion is advocating for harm reduction and removing the stigma against addiction and substance users. To that end, he's a peer clinical advisor for the BC Centre on Substance Abuse and advocates for coastal health and Ministry of Mental Health and Addictions. Welcome, Guy, and thank you for transforming your pain into something proactive that will help communities in BC and beyond serve their most vulnerable people. And while we're waiting for Guy to join us, like the other people that we've interviewed over the last couple of sessions that have such powerful personal stories to tell, they have taken those challenges and built something so positive out of them. And I applaud you all for that. And welcome, Guy. I'm just really looking forward to our viewers hearing your amazing story.
Hi, everybody. Thanks for having me. I'm always, honored and humbled to be able to share, some of my journey. It started off a lot of childhood trauma, growing up with a lot of abuse, domestic, verbal, physical abuse that really, crippled me as a young person. I developed anxiety, depression, self-hatred, and tried to find ways to cope with the pain that I was dealing with. My mom, drank a lot of alcohol. My father was a compulsive gambler, so he was rarely home. And then for me to try to get attention was very challenging. My parents were non-existent in my life, emotionally, yes, physically and material-wise. We had money, we had a house, went to school. I started struggling a lot in school, which then attributed to a lot of the verbal and physical abuse that I started to endure as a child. My parents blamed me for the issues in the household. I have one brother and one sister as well who visually weren't present when the abuse would happen. They were there, they could hear it, but they did things to protect themselves by going in their room. I was more of a visual person. And then, I navigated around my household, as a young child, knowing where the cracks in the floor were. So when you think about being 7, 8 years old and knowing this, so you don't startle people, or I describe it as, a soldier navigating a landmine field in a household. It was a matter of the bomb was going to go off when. It was just a matter of what day it was. And for me, I started to, look for ways and means to cope. As a young child, what I was coping with was unsurmountable amount of pain, and for whatever reason, I started playing. I was really good at sports, and so when I was on the soccer field or the baseball field, I had this distraction where I just wouldn't think about, or worry or have anxiety. I just play. And that gave me the freedom to have the ability to function somewhat. And then obviously, though, those games and practices are so far and few in between. You know, you may have one game on a Saturday, and then you know, you go back home to this abusive household. I'd gone through, you know, my mom would leave constantly, battered shelters, go to her grandmother's house, and we'd stay there, or at her mother's house, and we'd stay there, and then we'd always go back. And by the time I was 12 years old, I just, you know, realized that my family was, you know, not fit to actually take care of me. So I started running away from home, and then at a very young age, you know, started venturing into, at that time, which was the Granville, Hastings area, which was pretty predominant in drug trafficking and et cetera. And, you know, a little bit more, less intimidating, I should say, is the complete downtown east side, which I eventually developed to go into. But I was in there as a young child, and then obviously the police would, you know, I would be arrested and then brought back home to the abuse. And eventually started to, you know, I describe it as finding one of the greatest things in the world, which was street drugs. You know, street drugs gave me the ability to function through life, function through the anxiety, the depression, and the self-hatred. You know, I was self-medicating. I was diagnosed at the age of 40 with ADHD and a mild comprehension disorder. But when I was a child, I was just called difficult, hard to manage, and very hyper. So a failure on the system's part. And then, you know, by the time I was 14 years old, I was picked up for crimes to support my substance use and was sent to jail. And that was the first time that my mom actually went to court and physically, publicly stated that that I was the cause of all the issues in the household, and that the reason why things were the way they were was because I was a constant person that was causing issues publicly. Brought a lot of shame onto my family, and then obviously they gave me up and made me a ward of the court. And that, to me, at that age of 14 years old, was really kind of the moment in my life. I didn't really understand at that age what it meant, but I remember the probation officer explaining it to me, like that once you're finished your incarceration at 14, the province will now take over and move you into a safe environment. And when you hear that, when I heard that, I even though I know you struggle with all this abuse as a child, there's still your parents, and there's still your brother and your sister there, and you still, no matter how bad it was, even though it was bad, it was familiar and something that I learned how to cope with. To some extent. And then the province failed miserably by bouncing me around after I was released from group home to group home, from school system to school system, where my drug use just became very more progressive, where I started, you know, using hard drugs. And then eventually, as a young child, a young teenager, found myself homeless in the downtown east side of Vancouver. And once I started to go into the downtown east side of Vancouver, the group home area that I was last in was the Dunbar area, which was a nice area. And that was the last place that I had any stability. I never had any, you know, stable stability or stable housing. It was always contingent either on violent outbursts or being moved, which brought up a lot of issues with being, you know, discarded, abandonment. And as a young child and a formidable mind that you're trying to form, and, you know, believing all the lies that people have been saying about you, that you're the problem, there's issues with you, I just dove in headfirst to the drugs. And really what the drugs did for me is they gave me the ability to numb the pain and not really care what people said about me, or what I didn't really care what people thought of me. People didn't know me, but they knew that I used drugs, and that was enough for them to pass this judgment in my life, and look at me as a junkie or a piece of garbage, very stigmatizing. And you know, I'd felt the impacts of the full impacts of what enforcement and an enforcement act is, and the criminalization of people who use drugs. Has ever felt, especially in the 80s. Harm reduction wasn't even a word at that time. and it was all about the enforcement. And I had to do things to self-medicate from the pain, and living new trauma relives this old trauma, and so it was just this vicious, continuous cycle of trauma after trauma after trauma, and trying to navigate my way through this thick layer of pain, and it kept me trapped for decades. And it was in about 1993 that I met a lady named Liz Evans, who's started the Portland Housing Society, and um, she handed me clean supplies of syringes and waters, and I remember thinking to myself, "What's this?" It's not something that I was used to. I was turned away from pharmacists to ask for a syringe. Usually what would have to happen is you'd pick it up off the street. In those days, you'd bleach it and then sharpen it as best you could, and you'd use it, which caused severe health complications for people. And then, the Portland Housing Society came in 1993, and I remember Liz saying to me, "Listen, you're a human being. It doesn't matter that you use drugs. You should be treated like a human being, and I want to provide that for you." And for me, it was one of those moments that I'll never forget. It was like somebody didn't judge me for what I was doing. They were actually trying to just support me, and then that meant a lot. And obviously, in my life, I struggled with heavy substances. I would inject cocaine and heroin 30 to 40 times a day, and before even the supervised consumption site existed. And then in 2003, when the supervised consumption site existed, it kind of people use these facilities today for different reasons than why we used it. I was using a supervised consumption site in 2003 because of the police brutality that people who use drugs face on a constant basis just because you're using drugs. Imagine, even if your only crime in life is that you do drugs, and be punished for it. You're just a person that uses drugs, and for whatever reason why you're using these drugs, whether it's trauma or enjoyment or intermittently or whatever, just to be punished for that and then not know the story behind it. And I've had many police officers reach out to me over the years to actually apologize to the way that they treated me, saying, we were trained in law enforcement, and that's exactly it. Drugs were against the law, so we use the law to punish you, but not caring about why you were using the drugs. It's kind of interesting in the development of my life, even with my substance use, is that I never overdosed once in 20 years in using heroin. I mean, never once. And then in 2012, which was really the induction of fentanyl when it started to hit the streets, I had to be brought back to life 6 times within a 9-month time frame. And if you think about the tremendous amount of stigma, discrimination, and punishment that has existed for decades towards substance users. I survived the first dueling public health emergency, which was the HIV crisis, and also the overdose crisis, where actually 1 in 4 were infected with HIV in the area that I lived in. I've survived 5 osteomyelitis bone infections, 4 in my left leg, 1 in my back, where I had to learn how to walk again. I've survived numerous rhabdomyolysis infections in my body as well, and then also being brought back to life 6 times. And you think about all that survival of punishment, surviving through all this punishment just to try to access the service. Nobody offered me any kind of treatment options. It was just, I was offered prison. That was what I was going to get, because first and foremost, people just looked at, you were breaking the law, you need to go to jail. Once you get out of jail, then you can figure it out. They had no plan in place. And still today, I look at it as the treatment industry or recovery industry. It's much harder today to access treatment and recovery services than it was in 2013. It was even easier in the 90s. And that is a complete debacle for what we're dealing with today, because there's many people, not all, but some, that who use drugs, want to get off drugs. And when you provide, we don't provide any hope by saying that the wait list is 6 to 8 weeks, before I could go through detox in 7 days. And eventually, by the time my 7 days is up, if I wanted inpatient or outpatient, I could access it. And so that doesn't exist today. If you have $30,000, I could probably come up with getting you into treatment in 2 days. However, if you're on income assistance or welfare, I mean, it's just a 6 to 8 week wait list. And, oftentimes I often share with people, what are you recovering from? And there's many different things. And some people are recovering from drugs, but some people are recovering from poverty, mental health, homelessness, anxiety, depression, whatever it is, we're all really in recovery, each and every one of us. But yet, when we look at people who use drugs, we support them when they're in recovery, but we punish them when they're relapsing or if they're using. And to me, I think what needs to happen is there needs to be a tremendous amount of shift in the way we view substance use and mental health conditions, or even the way people use drugs. This is 2020. It's not 1970 in the Nixon era. And one of the things for me in my life was the empathy and compassion that people provided at the supervised consumption site. My last overdose at that facility was February 18th, 2013. I used the supervised consumption site 4,088 times. I overdosed there 5 times. Luckily for me, the one time that I overdosed out on the street, a nurse was walking by. So, you can call it kind of this destiny of how my life unfolded. And at that particular day when I'd overdosed and woke up, the nurse was in tears. I was out for about 10 minutes. And at that time, it was an alarmingly long overdose. Most people were up in about 2-3 minutes. She honestly thought that I wasn't going to come back. And when I woke up and pulled the tube out of my throat, she was in tears. And I asked her why she was crying. And you think when you come from an overdose and you see somebody in tears, that was the first thing I said, is, why are you crying? And she said, because I care, and I thought you weren't coming back. And to me, at that moment, that was something that meant a lot. And, on compassionate grounds, they sent me up to the second floor detox. And it's actually March 18th. Of 2013 was the last time that I'd ever used illicit substances in my life. I managed to make the leap to recovery services. I sought trauma therapy, and my life improved dramatically today. I live a pretty blessed life. I have a beautiful wife. I have 3 beautiful children, just a newborn that was born in July. I have a career job, and for me, I advocate for a lot of my friends that are no longer here, and I also advocate for people that are in recovery. And for me, I've always been a person that believes in meeting people where they're at and allowing them the option to go wherever they want to go. I just want to support people on their journey, and I found in my life that that gives people comfort because it's their journey, not mine. My expectation on my life is different from an expectation on somebody else's life. And if we can move instead of this support, a judgmental way of things and stigmatizing people, if we could move from that to a more supportive model, then sky's the limit for people who are struggling with substances, who want to use drugs. I believe that there needs to be treatment on demand in this province, and one that meets people where they're at. And that treatment could be a safer alternative to the toxic drug supply. And also that treatment could mean immediate access into recovery services. And if we can do that together, then we could change everything. Thanks for listening, everybody.
Thank you so much, guys.
Thanks, guys.
Great, thank you. So the story that you heard from Laura this morning, along with Lawrence's insights and Guy's amazing story, lead us perfectly into this session's keynote by Stephanie Knaak, PhD, called Stigma, the elephant, in every room. Stephanie is a researcher with the Mental Health Commission of Canada and principal of Insight Research and Consulting. Her research specialty These include mental illness and substance use-related stigma, Canada's opioid crisis, and workplace mental health. She's published more than 50 academic articles and research reports on these topics. Her current research focuses especially on mental illness and substance use-related stigma within healthcare systems. Hello, Stephanie. Thanks for joining us. We so appreciate you being here.
Hello, Joe, and thank you so much for having me. Hello to everybody who is listening today. It is a real honor to be a part of this summit and to be able to participate in this session today. And yes, I mean, going after Laura and Guy is definitely going to be a challenge. And I thank them both so much for their incredible courage and passion and for sharing their stories. So yeah, I'm going to talk about stigma today, which really is the elephant in every room. And I think, you know, as Joe mentioned, we heard so much about stigma already, as evidenced in Laura's story and Guy's story and in Lawrence's comments earlier as well. And I'm going to share some more bad news as well with you in terms of, you know, giving some examples and trying to frame ways in which stigma shows up in the context of substance use and homelessness. But I hope that I'm also able to share some messages of hope today, and offer some suggestions for a path forward and share some promising approaches for ways that we can tackle this beast of a problem. So with that, maybe I'll just start with a bit of getting our grounding in terms of, you know, what do we mean when we talk about stigma? You know, what is stigma? Because we use the term a lot, but we don't spend a lot of time really explaining what it is and defining it. We use it in conjunction with talking about negative stereotypes, prejudices towards people, against people, negative attitudes. We see it show up in labels and language that we use. We often use the term, you know, one thing that I hear a lot is people talking about the concept of stigma and discrimination, the problem of stigma and discrimination. And I think when we talk about it that way, we tend to isolate stigma as more a problem of attitudes and stereotypes, and we keep discrimination as something a little bit separate, that stigma maybe causes discrimination, but that it's still separate. And what I want to emphasize today is that it's not actually separate. In our concept, you know, what we mean when we talk about stigma, stigma is discrimination. It's stereotypes, it's prejudice, it's negative language, it's the labels that we use, it's how we frame problems, and it's also the behaviors that we enact. It includes discrimination, it includes unjust policies, it includes laws, it includes institutional practices that demean and that exclude and that restrict opportunities for people. So how does it work? There's actually a fairly robust social scientific literature that describes the concept of stigma and how it works. And how it's described in the literature is that it's talked about as a social process, a very complex social process that includes multiple different phases and exists at multiple levels simultaneously. And so how it begins is with the process of labeling. First, we label someone as different. I think Lawrence kind of spoke to this earlier. We create a label. From there, we can move easily to separation, the sense of separation between us and them, and this kind of othering. From there, it's not a very far leap to be able to devalue the stigmatized person. And from there, it's also not a far leap to engage in discrimination and actually be able to justify discriminatory behaviors and practices. And the reason that discrimination can then be justified, that stigma can be justified, is because you have all of those other components of the process that are now reinforcing and validating that end result of discrimination. And now the other thing I just want to highlight too is that in this figure here, the arrow is kind of going one way, which suggests the process just kind of goes that one way. But that's not in fact the case, right? All of these components work together and they reinforce each other. And so there's feedback loops all throughout this entire process. So what does that mean for when we're thinking about how to combat stigma and tackle stigma? It means we need to think about how to disrupt this process. And we can disrupt it because all these components are all interconnected and self-reinforcing. We can disrupt it at any and all of these different junction points, right? So we need to focus on the discrimination piece, but we can't do that in isolation. We also need to focus on our labeling and our language and how we're framing and talking about mental health and substance use and homelessness. And we also need to very much focus on that othering and devaluation, right? The human connection and the separation. So we need to tackle it at all of these different levels in all of these different areas. The other kind of key concept with respect to stigma is that it exists at multiple levels simultaneously. And again, all of these different levels of stigma are self-reinforcing, and they feed on each other and they support each other. So again, when we're thinking about tackling stigma, we need to think about going after it at all of these different levels. And so that includes the level of the self, self-stigma, which is, we've heard a lot about this already, the shame, the hiding, the feelings of low self-worth, the reluctance to seek help. We know that self-stigma drastically interferes with recovery. It interferes with help seeking. It interferes with human connection. It interferes with quality of life. So tackling stigma at the individual level. Interpersonal stigma refers to that public level of stigma. It's the attitudes and beliefs that we all carry. It's how we behave in our everyday lives, how we treat the people around us, how we think and how we act. So I think of this. I think of this level of stigma. This is the stuff that happens at the level of everyday personal relationships and interactions. Structural stigma is that level of stigma where we see stigma embedded in our institutions and our organizations. So in our laws, in our policies, in our decisions about how we allocate resources. As I talked about, the lack of access to treatment services is a classic example of structural stigma, as is the criminalization of drug use, as is the difficulty accessing safe supply, and we can go on and on. So these are all examples of structural stigma. We also know that stigma is intersectional. So the effects of stigma are compounded for people who face additional experiences of marginalization and oppression. So the intersection, say, of substance use and homelessness would be a classic example of intersectional stigma, where you have those compounding effects. So I just want to spend a few minutes maybe talking about drug use stigma specifically, because I want to draw on some research that we undertook at the Mental Health Commission a couple of years ago. And in this research, we were trying to learn about the problem of stigma in the context of the overdose crisis. And so we were looking at kind of the so-called front lines of the overdose crisis. So we were interested in talking to all kinds of different service providers, first responders, police, healthcare providers, social service providers, and also people with lived experience, many of whom had also experienced homelessness. And we wanted to understand how stigma was getting in the way. What does it look and feel like? What's going on here? And I'm just going to share with you a few findings, and I'll share with you some quotes from our research as well to bring some of these findings to life. But one of the big things we found is that stigma is highly present still in the attitudes and beliefs of people, and this even includes many professional service providers. And some of the most common attitudes and beliefs that we saw, or that keep coming up again and again, are this notion of addiction as a choice. That opioid agonist therapy and other similar kinds of medication treatments are little more than substituting one addiction for another. Notions that harm reduction is really nothing more than enabling the addiction. And we see this narrative actually playing out before our eyes very vividly these days in policy discussions and policy decisions. In Alberta, for example, would be one place where I'm seeing this narrative show up a lot. This notion that people must hit bottom before they can get help, or perhaps before they're deserving of help. Guy talked about this as well, this idea that people with substance use problems are less worthy or less deserving of care. And this experience was felt, this perception, I think, was shared even in a more compounded way with people who were facing intersecting stigmas. So this was a really, really big one. And also very narrow views of recovery, right? Still using old models of recovery, the language of recovery, very abstinence-based, views of, relapse as failure, kind of overall low belief in recovery, and really not enough focus on this broader idea of just wellness, quality of life, and supporting people. And the problem with all of these negative stereotypes and beliefs is that even though a lot of people in our study, intellectually could challenge these stereotypes and beliefs, they were still operating under the surface. Sometimes they were explicit, but lots of times these kinds of stereotypes and beliefs were operating under the surface in that they were used as a foundation to endorse different kinds of punitive policies or restrictive approaches to care. So they were used to justify kind of structural stigma. And I think folks didn't even really realize it in a lot of contexts. And I'll just give you an example. This wasn't from our research study, but this was just a more recent conversation that I had with a colleague who was sharing. She was sharing the success of the implementation of a virtual OAT program in her jurisdiction, in her health jurisdiction. And it was implemented as a result of COVID. And what they were seeing in terms of early results was that people were staying in treatment longer, and that they were also bringing in a wider variety of clientele. So they were seeing people in the clinic that they weren't seeing before. And so she was kind of talking about it as being as a stigma reduction initiative, that really this is an example of, we're kind of dismantling some aspects of stigma here because people are more willing to seek help in the virtual environment. It's safer for them, it's more comfortable for them. And she said, even though a lot of jurisdictions are going back to fully face-to-face, in a post-COVID world, we don't want to do that. We want to keep the virtual model alive and well. And in fact, we want to expand it. The challenge she was having is she said, we're having a hard time finding providers who are willing to get on board and do the virtual delivery of care. She said, what I'm coming up with all the time is providers saying, what do you mean? People have to demonstrate that they're committed to this. That's why we have them show up in person. They have to, so it's this notion of demonstrating that you're worthy and that you're really serious about this treatment. And we would never see this kind of conversation or this kind of rationale being used in the context of any other health condition, right? When people are ill, we just treat them. We don't expect them to have to prove themselves in any way in order to be worthy of that treatment. So that's kind of an example of how those attitudes and kind of policies or perceptions about practices and approaches to care went together. We also talked to people with lived experience, and the experiences of stigma that they had were perhaps, again, unsurprising after hearing Guy's story. They all spoke about having experiences of being treated in a demeaning manner, feeling punished, feeling patronized, humiliated, rejected, being subject to punitive policies, coercive practices. They face many, many barriers to access of services, many even services that were, theoretically built for them, and outright being denied care or being denied services in a number of different contexts. People talked about having high levels of system mistrust that in many cases, especially most often really in the context of healthcare, they talked about actively avoiding healthcare services because they would fear being mistreated or even harmed. And of course, the theme of self-stigma was very, very prominent. People talking about the shame, sense of failure, hiding, feelings of low self-worth. And here we have, I'm going to start showing you a few of the quotes from our research just to bring alive some of these themes a little bit more. And I think the first one really highlights how stigma really does become the ultimate barrier because it is, it does exist at all of these different levels and it's all kind of compounding and intersecting. And this one respondent, I think I had asked her, what is the impact of stigma, or how does it get in the way? And she said, well, stigma dehumanizes people. People don't access services. People aren't taken care of when they do access services. There are assumptions made, and people use a loan because they don't want anybody to know. So here's a couple of respondent comments that speak to this issue of self-stigma that we've been talking about. The first one, I think, really articulates the sense of shame and the feelings of shame from experiencing substance use and homelessness. And the second one is in relation to the hiding that goes along with it. These quotes here, I think, speak to the system mistrust and the avoidance of healthcare services. And what you can see here, again, is this reluctance to access services because of a fear of being poorly treated. And that, again, this mistreatment or the fear of being mistreated and wanting to avoid services was compounded for people who were facing multiple stigmas. Here's a couple of quotes that provide examples of that kind of interpersonal level of stigma, experiencing kind of negative experiences in their context of seeking care, receiving care, accessing services in some way. And here we go one level higher to the actual denial of care. And a couple of examples of respondent comments in this context. And I think what these kinds of comments highlight is that these issues of denial of care are not always actual institutional policies, right? They're not actually built into the system in terms of a policy. They can exist informally, but the outcome is still one of being denied care. And that's another way that structural stigma, I think, exerts itself, is in that kind of institutional culture, the culture of caring. And here's a couple of examples of actual policies that ended up being exclusionary, typically for the people that they were actually designed for. And the second one always really resonates with me. You know, this notion, you know, a sign on the door, if you've used drugs today, please come back tomorrow. Well, that seems like a perfectly reasonable thing to put on the wall. But if you use drugs every day, that's like, I can't ever come and use your service, you know, even though you are a service provider meant to help people, you know, with substance use problems. And you've so been brazenly unthinking that you could use a model like that. And the last quote I want to leave you with just kind of highlights, again, these compounding impacts of intersectional stigma. The first one gives an example of somebody's experience who is, you know, experiencing substance use problems and homelessness as well, and the barrier of simply just not having buggy barns, right? And how that ends up becoming this structural barrier, this kind of stigma that keeps people out. And the second one speaks to the intersection of substance use with indigeneity and the stigma there. So what can we do about it? You know, it is a beast of a problem, and there's a lot of work to be done, but there is hope on the horizon, and we do have a building body of evidence that gives us all kinds of direction in terms of best practices and promising approaches to tackle stigma. And I think one of the things, if we keep in mind this idea of tackling it at all different levels and at all different components of the process, then we can really start to weaken it, right? We really start to weaken its seams. So if I had to highlight a number of, I think there's many priorities really to combat stigma, but if I had to just point out or highlight a few key things to focus on, that might be these. You know, one is the trust piece. We really, really need to focus on building trust. We need to get that figured out so that people, you know, who have substance use problems, who are experiencing homelessness, that they can access services, they feel safe when they access them, and that they're not going to be harmed further simply by reaching out and asking for some kind of help. We need to change how we see and think and talk about substance use and addiction, and this includes harm reduction as well. So it's about, shifting our frame and shifting our language so that we're getting out of all of those kind of old school, conversations about, addiction as a choice and attaching it to morality and criminality as well, and really making sure that the conversation is always squarely placed in the context of health and social justice and wellness and quality of life and supporting people. I think we need to focus on structural change clearly. We don't all have the capacity to do a lot of structural change in our everyday lives. We're not all decision makers, by any means in the system, but we have the capacity to advocate and to support changes, real changes in how we deliver services. And we need to focus on improving our culture of caring. So how do we do that? What is the way forward in terms of doing that? I think at a very first step, if we can commit ourselves to focusing on starting from a place of compassion as opposed to a place of judgment, I think we've already made huge gains. Because if we can start with compassion and agree that we start there, we are disrupting the stigmatization process at that level of othering and devaluation, right? If we continually come back to remind ourselves of our shared humanity, our common humanity, and we remember that at the end of the day, every single person, all of us, all we're trying to do is the best we can with the hands that we were dealt, the cards that we were dealt. And at the end of the day, every one of us is just wanting and needing to feel safe, to feel loved, and to feel valued, and that our life has some kind of meaning. And so I think if we start there, we're already as kind of our basic framework and just, getting away from judgment and focusing on compassion and shared humanity, we are already making progress. The other thing we can do is education. I think this is a really important piece. But as you can see from the comments here, the quotes, we're not really talking about just literacy-based education. We're talking about really shifting our understanding of what substance use is, about what addiction is, and moving away from that moral failings perspective, right? There was a lot of talk in our research, and this has come up time and time again, that there's a lot of information, but there's really a lack of good information and proper information. So it's about shifting our frame again, shifting our frame and our perception. And how do we do that? One of the best ways to do this, and this is supported widely in the literature, not just through our own research, it is through using personal stories. It's again, hearing people share their experiences, understanding their lives, and using that specifically as an educational tool to combat stigma. And the graph that you see here in front of you is an example. It comes from an evaluation that we recently undertook at the Mental Health Commission of Canada, where we were able to compare two different interventions and take a look at what their stigma reduction impact was. The first intervention was an educational intervention, which basically all it was measuring the stigma reduction impact of the regular educational curriculum content that nursing students were receiving on mental health and substance use, on mental illness and substance use. And you can see that it doesn't do anything, right? So standard kind of literacy-based educational stuff, it really doesn't do anything to shift the needle, to move the needle. But when you look at the social contact intervention, so here in this case, it was a woman with lived experience of substance use disorder. She came into the classroom, shared her story, engaged in a facilitated discussion with the students and with question and answer at the end. And you can see the stigma reduction impact in this case. It was quite profound. And that was only a 1-hour intervention. And we saw that those gains held at 3-month follow-up. So this is a really, really powerful way to do it. And this is where you're going to get that transformative learning component that we're really going for. I think we can do a lot just by paying attention to our language, the language that we use, the labels that we apply, and the intent that we use behind our language. Because, you know, we're not always going to get our language just exactly right, but that's okay. It's the intention of the language, right? How are we speaking about people? How are we thinking about them, and how are we holding space for them? And how we're framing our dialogue, how are we framing our conversations about substance use, about mental illness, right? That will go a long way as well. And that's something that we can all do in our everyday lives. Another really, really important piece is ensuring meaningful involvement of people with lived experience at all levels of service, advocacy, research, service delivery, and policy type decisions as well. And so this isn't just about using social contact as an educational tool. That's part of it, but meaningful involvement of people with lived experience gets right at the heart of what Lawrence talked about at the beginning of our session when he was talking about, you know, Brene Brown's work of the different types of power, that right now we live in a system where it's very much power over, and that is at the heart of stigma. But ensuring meaningful involvement of people with lived experience, giving them a voice and a seat at the table and the ability to then make change. You're moving to a position of power with. And so that's a really, really important piece. And I don't think that can't be emphasized strongly enough. The last one that I want to focus on is trauma-informed models of care. Guy talked about the role of trauma and being re-traumatized, and we heard this a lot in our research as well. That being able to provide care and to have conversations in a trauma-informed way, in a way that is also culturally safe and culturally sensitive, goes a long way to building trust, to allowing people to feel safe, and can promote healing. And the second quote down below is something that always really resonated with me, and I think it speaks to the role of trauma-informed models of care in relation to stigma very, very, very strongly to me, right? She says, and this woman, she lost her husband to an overdose, and she says, you know, he missed a lot of appointments. I get it. But they need to understand the symptoms that come with the condition and work with them. Like being able to recognize when a client or patient is lying to you is not impressive, but creating an environment where someone feels safe enough to not lie, that's impressive. So I'm just going to leave you here. I'm sensitive to time, so I don't want to spend a lot of time on this slide, but I do want to share it with you. This framework for action, it kind of, you know, we can think of it as a little bit of a summary slide of the things that I've talked about. But this also came out of a report that we put together at the Commission earlier this year, where we were trying to integrate findings on research that we did on trying to understand mental illness and substance use related structural stigma in the healthcare system. And this framework for action was what came out of that in terms of identifying what are some of the key areas of focus, where do we want to direct, where do we need to be directing our attention? And you'll see here from these different things, there's a number of things that I've already talked about today, the meaningful involvement in service delivery and advisory, research, training, and peer support roles of people with lived experience, the education and training piece to really be stigma informed and shifting those attitudes and that culture of caring. Adopting recovery-oriented models of practice and also measuring stigma, and also tackling our legislation and our policies and our practices and ensuring protections for people. I'm going to leave it there. I think we're at time and we need time for discussion. This last slide, I might just leave up for a few minutes. It gives some additional resources. These are some of the resources I drew on today. And these are available for anybody who's interested in perhaps learning more, reading more, and they're all freely available. Most of them are available on the Mental Health Commission of Canada's website, but I can also get them to anybody who's interested. Thank you.
Thank you so much, Stephanie. Very, Very interesting and important work that you're doing. We've run out of time for questions, but Stephanie will be joining us during the panel discussion. Also, if you have any questions for Stephanie or any of the other speakers that aren't addressed during the panel discussion or the Q&As, please send them to me, jo@freshoutlookfoundation.org. And I will make sure that your questions are passed along to the appropriate speaker. So moving on, science has a huge role to play in how we think about substance use and homelessness, and ultimately how we improve diagnosis, treatment, policies, and programs. Our next guest is a great example of the potential that science can unleash. Jacob Stubbs is a PhD candidate in experimental medicine at UBC. His research focuses on how the health of homeless and precariously housed individuals is affected by traumatic brain injury. Jacob volunteered at the Overdose Prevention Society and recently co-founded Zero Block Society, a harm reduction focused nonprofit. Well, thank you for doing that. And Jacob, thanks for joining us.
Thank you. Well, good afternoon, everyone. My name is Jacob Stubbs. I'm a PhD candidate with the Experimental Medicine program at the University of British Columbia and affiliated with the BC Mental Health and Substance Use Research Institute. And today I'm going to give you a brief overview on what we've been looking at with some research on traumatic brain injury, substance use, and unstable housing, as well as homelessness. So I come to you as a trainee with the Hotel Study, a member of the Hotel Study, which is a prospective and longitudinal study in Vancouver, BC, where the study team has recruited participants since 2008 from single-room occupancy hotel rooms in the downtown east side. These SROs often fail to meet the minimum housing standards for Canada, just a little bit of background. And we follow these participants for up to 10 years. There's been about 500 participants that have been enrolled as part of our study. And they undergo a variety of assessments, including MRI scans, neurocognitive screens, substance use questionnaires, neuropsychiatric symptoms, housing status, etc. And I'll get back more into that a little bit later. But to round out the background, my research area of interest and focus is on traumatic brain injury, which is just very broadly a force exerted on the brain that disrupts normal functioning. There's a wide variety of symptoms that can include headache, concentration difficulties, confusion, memory problems, dizziness, and the list goes on. And TBI is one of the leading causes of death and disability in Canada and the US. However, 80% are mild, so it's 80% have very little long-term issues. With that said, though, most of the research on TBI is in athletes or the general population. And this is in part because it's a little bit easier to study and it's less noisy. But it's also a problem because it leaves us with little information on how TBI interacts with other important factors like housing instability and substance use. So this, one of the first steps in our research was to look at all of the previous research that has been done on this topic. And so we synthesized this all in what's called a review and meta-analysis, which was published earlier this year in a journal called The Lancet Public Health. And it was pandemonium for us because it was picked up by many news outlets, essentially all the Canadian ones, as well as in the UK, including The Guardian. But the summary from this paper was more than half of people who have a history of homelessness or who are marginally or precariously housed, more than half have a history of TBI. And this is about 2.5 to 4 times higher than the general population. And that's what made headlines. But what I think is perhaps more striking is that we found that more than 20% had a history of what we would consider moderate or severe TBI. And this is more than 10 times the general population. And so just to give you a little bit of context, moderate and severe TBI is just associated with longer term issues in functioning and more severe symptoms over a longer period of time. So prevalence is, have you ever had a TBI? And incidence is simply, if we're following you for, say, a year, how many of you are going to sustain a TBI? And in this population, estimates range between 0.5% all the way up to 20%. And this is sort of highlights the problem. There's such a range of findings that it's really hard to draw any real conclusions. So we also found that TBI is associated with poor physical and mental health, self-reported, as well as suicide and suicidality. TBI is also associated with increased health service use and criminal justice system involvement. But we looked at many, many factors, including substance use, cognitive dysfunction, and homelessness. And for those factors, the relationship was very much murky and unclear. And that's partially just because there's little research, and the research has mixed findings. So much of my work and our work is focused on addressing these unknowns. So to start, I said I'm from the hotel study. This is from the downtown east side of Vancouver, BC. And we've done more in-depth screening of TBI and some studies there. So just to give you a little bit of background of TBI in the hotel study, about 80% of the participants in the study have a history of TBI, which is extraordinarily high. In terms of how people get them, it's most commonly through assaults. In the general population, it's falls, motor vehicle accidents, sports, and in the downtown east side, it's by far and away assault. And if you look by sex, females had significantly higher TBI through the mechanism of physical abuse, which I think points to some emerging work looking at intimate partner violence and brain injury. One thing that we can do, because our study has MRI scans, and this is one of my focuses, is we can look at long-term brain damage. And this would be from what we would call a moderate or severe TBI. And the figure on the right here is a brain scan going sort of through your head like that. And the red arrow just points to what we would call a lesion, brain damage from a traumatic brain injury. And in this study, about 7% of all participants have some sort of brain lesion that we can see on a scan that is attributable to traumatic brain injury. So one of the things that we have looked at is the relationship between people's first TBI and the onset of unstable housing. What's been shown many times before is that the majority of participants in studies receive their first traumatic brain injury before they become homeless. But we wanted to look at the relationship between severity and timing. And I realized there are a few graphs coming up, and I'll explain as best I can, but I'll give you a summary as well. So this graph here is looking at the negative numbers are traumatic brain injury happening before becoming homeless. The year of becoming homeless is at year 0, the dashed line. And what this is showing is that more severe traumatic brain injury is very closely related to the onset of initially becoming homeless. And then on the bottom panel here, on your y-axis, you've got the lifetime duration of homelessness, and on the x-axis is the number of years before becoming homeless. And what this is showing is it's going up as we get close to 0, and that's showing that as you get closer, or TBI closer to when you become homeless, is associated with staying homeless longer. And this also applies to precarious housing. So just to summarize quickly, more severe TBI is more closely associated with becoming homeless. And the combination of TBI and unstable housing or homelessness may represent a barrier to getting out of that unstable housing situation. So there's also data from prospective studies, and prospective studies are studies like ours that follow people over time. And we synthesized this all in our Lancet Public Health paper. Some of the data looks at risk factors, TBI causing homelessness or homelessness causing TBI. And so what previous studies have found is that TBI is more likely in those who are currently experiencing homelessness as compared to those who have stable housing. But on the other hand, homelessness is more likely in those who sustain TBI as compared to those without TBI. So this suggests to us that the relationship may be bidirectional and may represent, or traumatic brain injury rather, may represent a barrier to actually getting out of an unstable housing situation or homelessness. In terms of the relationship between TBI and substance use, this is a really challenging thing to study. And ultimately, there's little clear evidence that traumatic brain injury is a major risk factor for starting substance abuse or increasing substance use. On the flip side, though, alcohol and drug use is certainly a well-identified risk factor for sustaining TBI, especially alcohol use. But identifying risk factors that operate in one direction versus the other often has sort of limited clinical or frontline relevance in some ways. What I'm particularly interested in and what we're starting to focus on more is the combination of things like substance use and traumatic brain injury, and looking at how the interaction may either worsen your outcome or impair your recovery. So this is one thing that we can look at in the hotel study. This figure on the right-hand side here is looking at white matter integrity, which is from what's called a diffusion tensor MRI scan. It's broadly a metric of how well your brain's connecting fibers are sort of holding up. And it's completely normal to see this decline over age, which is our x-axis here. But what's powerful in our study is that we can look at everybody's individual change over time. So the blue line here is all of the participants on average, but we can also look at each participant individually, and that's everyone's individual line. Since we have multiple scans, we can look at individual trajectories here. And this is one of our key findings that's going to come out in a paper hopefully next year, is that on the left-hand panel, we've got people who have no alcohol dependence at baseline. Red is there's no TBI, and blue is there's a history of TBI. In the right-hand panel, we have people with alcohol dependence. And what we see in the right-hand panel, blue line, is the combination of alcohol dependence at baseline and a history of traumatic brain injury was by far and away the strongest predictor of decline in brain health over time in this way that we were looking at it. And this decline in these metrics of brain health is very closely associated to decline in cognitive functioning and other metrics of health. So just before I close, I want to give you a brief overview of what we're working on moving forward. This is becoming really interesting because we ran a study called the Hotel TBI study between 2016 and 2020 as part of the broader hotel study. And this is where we followed people every single month and asked if they had a TBI. If they had a TBI, we gave them additional assessments and brain scans. We also got someone who was closely matched to them, but who didn't have a TBI, and we gave them extra scans and assessments. And this study design will allow us to follow people over time and allow us to really closely look at immediate and long-term brain changes after traumatic brain injury, how these changes are associated with substance use, if substance use changes after traumatic brain injury, as well as other things like housing changes after traumatic brain injury. And heading into my last few slides, just a few preliminary results. One thing that we found is that there's about a 30% incidence per year, which I realize without context is hard to grasp, but it is just extraordinarily high. So about a third of our study sample is getting what would be clinically determined to be a traumatic brain injury in a given year. Alcohol, I should have put in here, opioid use, and previous history of traumatic brain injury were the strongest risk factors for sustaining a TBI over the study follow-up period. And my role is looking at the imaging. So on the left-hand panel here, we've got change in the control group. So the control group are the people that have no traumatic brain injury. And this is looking over about a year. And any changes would show up as either red or blue. And there's nothing. But when we look in change in those people who sustained a TBI, the diffuse red color all throughout the brain is showing a significant decrease in your structural integrity of those brain connecting fibers. So in summary, traumatic brain injury is very common and also quite under-recognized among people who are experiencing homelessness or who live in precarious housing. Traumatic brain injury and the loss of stable housing are things that we've looked at, and they seem to be associated. and the relationship very well may be bidirectional. And while substance use can be a risk factor for sustaining TBI, the combination of substance use and traumatic brain injury can interact to worsen outcomes. So I want to thank everybody for having me here and listening, and also acknowledge that I am one part of a massive study team that does a fantastic job. So I want to acknowledge them as well, and thank you for listening.
Oh, thank you so much, Jacob. That is just fascinating information. We're going to bring Lawrence back in for a question or two. The one comment that I would like to make is that and role in this particular area is huge, because I predict that what you find will help decision makers at a government level, for example. Their decisions will be much better informed by what you're learning through science. So thank you for doing that work. Now, I guess before you have a question for Jacob, the question I have for you is that your experience with people, substance use and homelessness challenges, is this sharing, does that resonate with you? Do you have you seen that in the work that you've done at the ground level?
Yeah, Joe, like over the course of 15 some years in terms of frontline work, this would be a daily experience for myself and people I've worked with. I mean, as much as Stephanie's, it's a good thing the volume was off from my end, but as much as Stephanie's presentation, you know, there's times where I'm yelling, yes, you know. I think with Jacob's presentation, there were times where I'm like, oh, yeah, you're right. You know, there's a real confirmation piece there. I mean, I think one of the pieces that, you know, that needs to be talked more about is the relationship between TBI and then the loss of stable housing, and the, you know, the work that's gone into at least identifying that there's a bidirectional relationship between those two things. That, you know, there's so many stories I can tell you. And again, I don't, you know, obviously I'm not going to use people's names, but I can rattle off one person's name after another who I know have experienced, you know, traumatic brain injury. And it's a key factor in their everyday life. And they have to wrestle with it and deal with it every day. And there are so many instances where it is either not formally identified for a bunch of reasons that Stephanie talked about, in terms of, you know, going to medical facilities or going to get the support structure, and then for all sorts of different reasons not being able to access, or not feeling like they're able to access those resources to even diagnose what they're carrying. And I think too, you know, that relationship that was fascinating for me, Jacob, was that early first experience. And again, I don't have anecdotal experience or anecdotal evidence for this, but there is a high level of anecdotal experience or correlation between people's encounter, their first encounter with chronic homelessness and TBI. And part of that, for those who are watching and listening, for many folks, you know, even though they may have dabbled in an addictive lifestyle, or maybe they've been struggling with mental health issues, for a lot of people, when they first find themselves on the streets, it is a very scary and a very sort of destabilizing experience. And for those people who've been in the streets, who've experienced homelessness for a long, long time, they have something called, you know, my friends at street level would say, we have street smarts. We've got, you know, my gut instinct or my BS meter is set high. And so there's this expectation that they know when somebody's going to attack them, when they're likely to be subject to some kind of unforeseen kind of violent incident. There's, you know, obviously at street level, it's referred to sucker punching. A lot of people will be attacked for what they don't, others won't necessarily even know why they're being attacked. I mean, there have been incidents in the city where I live where, a bunch of young high school guys just got drunk and decided to pick on somebody who was experiencing homelessness, who was asleep in the park, because it was an easy target and they knew they wouldn't face charges, or the likelihood of them facing charges would be very low. And so, and that led to a traumatic brain injury in that particular incident I'm thinking about. So, all that to say, Jacob, I mean, I'll finalize the question here, but in your experience, in terms of what you saw, in terms of the findings and the research, what was probably the most startling kind of statistical kind of realization that came out of the study for you personally?
I think clearly my research interest is in TBI and brain imaging, and the fact that in the study's 350 participants, about 7% had something where we could look on a brain scan and we could say that happened because of traumatic brain injury. That was by far and away, I think, the most startling thing that none of us would have expected, because not even 7% of the general population would ever report having such a severe traumatic brain injury, let alone having it be visible on imaging. But something that ties into that, but that was also startling, is we got so much media coverage over that review article that we put out. And I, against my better judgment perhaps, but went looking through the comments section one day just because I was curious. And usually the comment sections are just a train wreck, I find, especially on subjects surrounding homelessness and substance use. But this was fascinating because there was just an outpouring of empathy. And it was a lot of people, the idea that someone has a brain injury that you can see on an MRI scan, and you can perhaps attribute part of their aggression or behavioral dysregulation or challenges showing up to appointments. The idea that you can attribute some of that to a brain injury that you can see on an MRI scan is just a little bit of a key piece for people to be able to start having more empathy and start to a little bit understand it's a multifaceted, enormous challenge. And I just thought that was also neat to see, and hopefully a step in the right direction.
A discussion about stories behind the statistics, and initially Guy was to be the introduction story to that mini session there, and he went first today. So I'm just wanting to now introduce the number 2 speaker in that. His name is Dr. Mark Tindall, a professor at UBC School of Population and Public Health. He's an infectious diseases specialist, an epidemiologist, and a researcher. His current work focuses on harm reduction and innovative solutions to prevent drug overdoses through decriminalization and a safer drug supply. Thanks so much for being here, Mark, and I look forward to how you build on Guy's earlier presentation.
Sure. Okay. Thank you very much for inviting me. I've enjoyed listening to the speakers so far. I know Guy very well and enjoy the academic discussions. So I'm very happy to be here. Just as a little bit of background, I am an infectious disease doctor by training and an epidemiologist. And my career has basically been following the HIV epidemic, and that brought me to Vancouver in 1999, and I was a physician working with HIV prevention and treatment in the downtown east side, and I've done that for most of the time since then. And I became very involved in harm reduction work, and was the evaluator of Insight when it opened in 2003, and have been really working in the harm reduction sphere. I was the director of the BC Centre for Disease Control. I came back in 2014 to do that, and I was there for about 5 years. And to be honest, my goal at that time was to kind of move away a little bit from just working in the field of HIV and drug use, and expand my public health horizons. But it was really around the time I arrived that overdoses started to escalate in British Columbia and across Canada. And I became involved in that work again. And almost 2 years ago now, I left my job at the BC CDC really to focus more on the overdose work. And I've been focusing on that, and a project specifically I've been working on is called MySafe, which is a automated way to give out drugs. So it's an ATM type metal box with a biometric scanner, and there's people that can go and get hydromorphone from this machine. So that's been my focus. But I did want to talk a little bit today about just this major gap between primary prevention, which is the role of a lot of public health, and the other side, the medicalization of addiction and the recovery world. And between those two pillars is literally tens and maybe hundreds of thousands of British Columbians who sit somewhere in the middle of that, and are at high risk of early death. Overdose has become the primary way that's happening, but before overdose deaths, the life expectancy in the downtown east side of Vancouver, for instance, was around 50 years old. And so people's longevity for various reasons was also highly compromised, and people's quality of life was quite dismal before fentanyl arrived. So I think we tend to focus quite a bit on the primary prevention, and obviously we should be, improving youth mental health care and the foster child syndrome and family poverty and youth in unsafe situations. I think we need to do far more on that, and clearly that's a primary prevention focus that we need. And also to have a better medical system for addiction control. So, I prescribed methadone in my career, and I've done a lot of medical interventions in addiction, and that's really important. And then, we have quite a broad recovery model, quite broad recovery models in British Columbia, and clearly that's really impacted and helped a lot of people. But as I say, in between there, for people who have we've missed the boat, and they've been put into very vulnerable situations and are already using drugs, and we were not able to intervene early enough, and have already destroyed many of their connections. And then how we get people to treatment and possibly recovery, I think that's where the big gap remains, and it's kind of a messy, dangerous place to be, and that's why most people sort of avoid it. And I guess encapsulating that would be a lot of harm reduction. So people working in areas where we try to make lives a little bit better for people, make things a little bit safer. HIV was a great example where, you know, as Guy described, you know, finding needles on the street and sharpening them on a rock clearly was a risky thing for people to do, and simply giving them a clean rig was an important first step, and really reduced infections and with HIV and hepatitis C and also other bloodborne infections. And then we made the step, well, it's kind of crazy watching people, even with clean needles, you know, use puddle water and have to use their drugs, you know, in door stoops and in dangerous places. Why don't we just open a place where they can come and at least have a place that's warm and dry, and we can talk to people if they want to. And that was the concept between supervised injection sites, and you know, that I think that was a really important thing. But it's very frustrating and disappointing to know that the first site was in 2003, and the second sites in British Columbia didn't happen until the overdose crisis, and these overdose prevention sites opened, and there's about 30 of them now in British Columbia, and the rest of Canada is just trying to wake up, and a few communities in Ontario have very recently opened them, but that's almost 20 years ago, and we proved that they were very important and could really be life-saving to people a long time ago, and it really hasn't taken off like it should. And the thing with the overdose crisis happening now, we've really turned our focus to trying to provide people a safer supply of drugs, and that's what I've been focusing on. Again, with the outcome that I'm most interested in is keeping people alive and trying to get them to the next stage. And unless we do that, you know, treatment and recovery is just not going to be open to them because they're no longer here. I mean, when I was working as a physician in that community, people are on and off their medical addiction treatment almost continuously. So people on methadone and then more recently Suboxone were basically on and off it all the time. Their HIV medications are on and off it because we really hadn't addressed the reason, the underlying reasons, and the entrenchment that they were having in their communities. But the thing is, if somebody went off their methadone and started using again, they'd likely come back in 6 months and try again, and we give them another chance. With fentanyl, that doesn't happen anymore. People often don't get second and third and fourth chances, and so we really need to do something better. And so we've really tried to make this into the narrative of a poisoning epidemic and treat it like that people, it's quite crazy to know what's out there on the street, expect people to use it, and then not offer them any alternatives. So I think as an ethical next step, that's what we need to do. And that's what I'm committing myself to the next little while. The tied in very closely with that, and it's very timely that we're talking about the decriminalization today, because the Vancouver City Council just voted unanimously to decriminalize small possession of small amounts of drugs just last night, and hopefully that will go forward, because again, that's really the cornerstone of the violence and the structural violence that we've put people in. So we've treated people who use these drugs as criminals, and that's just been very damaging both to them and to communities at large. It serves really no purpose. I guess the idea is that if you criminalize something, it will dissuade people from using it, but clearly that has not worked, and drug use is going up, and it's not really a way to dissuade people from using, but once they are using, it's really a way to punish them. And when we think about what we want people to feel when they're considering, reducing their drug use or recovering, the key is to feel some sort of hope and some sort of self-worth and some sort of optimism of the way forward. And I can't think of a worse thing to do to somebody like that than to criminally punish them. So the whole concept of criminalization is just so wrong and unethical, and really makes huge, just as I describe it, kind of a black cloud over everything we try and do for people who are suffering from their addiction. It just makes absolutely no sense, and really is a huge way to stop people from moving on. And Guy would be a good example of that. And there's many people, almost everybody that I deal with in that community would tell you the same story, that spending your life dodging police, and if you get caught, being arrested by police and put in detention. I mean, it's just a crazy thing. Nobody could think of a more radical thing to do to people who use drugs. So when we think of, when we discuss what can we do, I mean, as a community of concerned people, we have to do a far better job of advocating for really very radical structural changes. I mean, my 20 plus years working in communities with drug use, mostly the downtown east side, but I also spent 4 years in Ottawa in much the same situation. I've had the opportunity through my academic work to see a lot of different cities. I've had the opportunity to travel a lot, and instead of trying to find the best restaurant in a city, I try to find the best drug scene in a city. So I've really tried to understand the best I can how these situations work, and the environment people are in. And it's the same, pretty much all over the world, that once people are using drugs, they're prosecuted and chased around by criminalization. So when people ask me what can I do, or what can we do, it's really lobby hard for change in the environment that people are living. That decriminalization, I think, is a critical component of that, and really investing resources into social services and trying to get people back on their feet, and not punishing them and making them live in the worst conditions, and spend a little bit of income they have on drugs. So I really I've gone from kind of a clinician to an academic. Now I'm more or less an activist, I think. And I mean, we really need to figure this out for people, not focus entirely on primary prevention, not focus entirely on the recovery, but really try to meet people where they're at right now, and give them a chance. And yeah, that's my message.
Thank you so much, Mark. We are going to bring you back a little later for discussion, but I have a quick question for you. Can you tell us what the link is between substance use and homelessness? Are all people who are homeless also struggling with substance use, or what are the sort of the statistics there?
Yeah, I mean, definitely not. I mean, there's pockets certainly that get the most media attention in Vancouver and around BC of 10 cities. And I would think that drug use is quite prominent among that. Certainly not everybody in those situations, but it's a vicious circle. I mean, people are living with a lot of pain and trauma and discomfort, and substances are a way to try and deal with that the best way people can, I think. But it really does take away our empathy, especially when it's a criminalized behavior. If we saw, 100 people living in tents and mud in some field, we'd be very quick to try to intervene and give them something better. But if we say, well, they're just drug users living in tents and mud in a field, somehow our empathy is taken away, and we're going, well, they chose to do that and they shouldn't be using drugs. So I think, people's situations are the same, can be the same whether you're using drugs or not. But I think yes, the drug, the drug label really does stop us from taking the action that we know we should be taking.
Well, and also, I've been watching some documentaries on television about COVID-19 and how a large percentage of the population is just one paycheck or two paychecks away from losing their homes. And I'm sure that a lot of people who are in that situation end up being homeless, and we judge them for all kinds of other things that we shouldn't.
Yeah, it's very easy to label people. That the person Stephanie, I think, talked about the stigma thing, and the labeling. The way people think about this situation is the way they end up acting, and the way you deal with your empathy and how you look at some person. It's way easier to label them negatively and walk by than to say, "Wow, they've had a really rough time, and we should be actually helping them." And drugs and criminalization really taint our empathy.
Thank you, Mark. And as I say, you'll be coming back. But our next presenter in this session, called Stories Behind the Statistics, is Tom Smithwick, a retired lawyer and former Kelowna City Councillor, who is now director of the Freedom Store Addiction Recovery Program for Men in Kelowna. For his long-standing and far-reaching humanitarian efforts, Tom was awarded the 125th Anniversary Medal by the Governor-General in 1992, Kelowna's Man of the Year in 2000, and the Caring Canadian Award from the Governor-General of Canada in 2005. This year, he was presented the BC government's prestigious Good Citizenship Medal. So, hi, Tom, and thank you so much for joining us. Hi, Tom.
Hi, Joanne. How are you doing?
I'm good. Thanks so much for joining us. So happy to have you here, and look forward to hearing your stories.
Well, thank you. And thank you to everybody who's involved in this summit. As Joanne said, I've been involved with Freedom Store since its outset, since the beginning. 18 years ago, we began Freedom Store. Freedom Store is a recovery home for men suffering from addictions, as you've heard, in Kelowna, British Columbia. We own 7 homes, duplex-style homes, and we house 64 men each day in a long-term recovery program. Men are entitled to stay as long as they wish. The attitude is being a part of a family or a brotherhood. The attitude is being a part of working together as peers in order to receive recovery and healing. Each person is also treated as an individual, because every issue is, everybody is unique. Everybody has their own particular history and experience. And so what Joanne has done is she has asked that I put a face on the picture of addiction. So what I'm going to do is I'm going to tell you about one particular resident who, I'm going to use a pseudonym. His name is Abe. Abe was conceived and born of 2 teenagers. Before he was born, his father died. Therefore, he was raised by a young, inexperienced woman in poverty. She was trying her best, I'm sure. And the difficulty being that when one is very young and raising a child, that child is left somewhat helpless, defensive at times, depending on the situation. In this particular case, in order to try to survive, the young woman took to drug dealing as her source of income. She was also inexperienced and was, of course, a young person and going through a life of partying and drug use and drug dealing and so on. Many men coming in and out of the home. A young boy who had hyperactivity, probably ADHD at that time, was struggling to get some attention, but little boys do not mix particularly well in a party scenario. He was then often placed in and locked in his closet in his bedroom for hours in order to have him out of the way while the adult activities go on. And that life of fear and struggle and abandonment and lockup was what Abe experienced as a young child. He then went off to school, but of course, Abe was poor. He had some struggles. He was different. He was an easy target for abuse and for bullying, and he experienced that. So Abe had really no safe place. He had no safe place to go and to understand what his life was and what he was going through in his life. He then, at age 11, decided, like his mother, if she was going to be a drug dealer, then he would too, in order to get his own money, in order for him to survive. And he went on as a drug dealer at age 11 for a time. But then when his mother discovered it, she decided to call the police in and brought the police in and advised of his drug addiction and his, in fact, drug dealing. He was then sent off to a juvenile custody center. And he then, at 11 to 12, was in this custody juvenile center for a year. At the end of the year, he was sent back to his mom. While with his mom, at age 12, he was raped by one of his mother's girlfriends on the living room couch. And it was after that, with a sense of anger and no trust of any adults whatsoever, that he moved and lived to the street. He decided that life on the street would be better than life at home. And this story is repeated, and we've already heard this today, that that's often what happens. And one tries to find a safe place, tries to put a balm on the wounds, balm being BALM, of course. Drug use is prevalent. Life in the street for a 12-year-old, of course, would not be easy. Criminal activity ensued in order to survive. Probably the best meal was out of the garbage bin behind the local pizza shop. And life went on with that for a number of years, associating and trying to survive on the street. At age 17, Abe was in a fight encounter with a gang. The gang used rocks in socks to beat him, and he was severely beaten. He ended up going through many months of rehabilitation in the hospital in order to have plastic surgery to reconstruct his face. He also received brain injury, and of course, in this case, there was no cure for the brain injury. This would be a lifetime of enduring brain injury and living on the street. After months of rehab, he was then released, and he's now back on the street, an angry person, a person who trusts no one, a person who has little or no hope, a person who is simply trying to survive, and now with a brain injury. Abe came into Freedom's Door when he was 22. He left the community he was in and came to Freedom's Door. He heard about it and was directed to it, so he arrives. But he's still a very angry and non-trusting young man. But he came into Freedom's Door, into the home, and he is surrounded by people who are also trying to get well, also trying to seek some help and some hope. And he became, in time, a very warm and accepted member of this small community known as Freedom's Door and the brotherhood that is there. When he first arrived, his reading was about at an age, grade 3 level. He was taught by his peers, the other fellows at Freedom's Door, how to read. And within a year, he was reading at a very high level. He became a part of the broader community as well, because at Freedom's Door, what we try to do is to link them into not only services within counseling and other services, group counseling sessions, individual counseling sessions, trauma treatment sessions, and so on within Freedom's Door, but he was also linked to the broader community to get services in the broader community of Kelowna and linked into that. He also joined various communities, joined a youth group that very much accepted him, joined other communities where he fit in, where he felt warm, where he felt comfortable, and could partake in the activities that he took joy in and loved being a part of. So Abe was very successful in overcoming the traumas that were his childhood and his young life, and was able to join a community where he found love, and he found family, and he found brotherhood and acceptance. So that's the story of one particular resident. But I think we need to move beyond to every individual's story is a different story. Every individual's experience is different. And we need to recognize that everybody has to be treated in that way with respect to who they are, where they've come from. And also recognizing that, and we've talked about it here, we've talked about stigma in the last number of hours. We've talked about being treated differently because there's a label or a name put on somebody. We're all individuals, we're all humans, we all are, I believe, totally good at the core, but it's trying to take off the things, the abuses, the traumas that have been our life experience, that to get to that core goodness that I know that we all are, and that the people who come and see us and seek help from us, we need to help them to get down to that core. Coming into Freedom Store is often with anger, it's with trepidation, it's with fear, it's with a total lack of a feeling of self-worth, with often feelings of hopelessness. But you know, our experience is that it isn't hopeless at all, and we should not have an attitude of hopelessness at all when it comes to helping people who have struggled in this way. Dr. Gabor Mate is really a world-renowned expert in the area of addiction. He worked in Vancouver's East Hastings, et cetera, for many years. He's written a number of books. And he says that in his belief, addiction comes from pain. Addiction comes from trauma. And particularly at early ages, when traumas and pains are felt, and that confusion as to what is happening in life, it can often lead to addiction. And if addiction comes from pain and from trauma, then surely we, as part of our work, have to look at the painful experiences that the person has endured, the traumas that they have endured, and start opening up those things in order that the person may be freed of those traumas, freed of the pain that they're suffering on a daily basis, and go to a place where they can say, this pain, this trauma doesn't define me. It isn't who I am. I can take it, look at the truth of it, and then put it aside and move on and away from it, hopefully in a way that then enables them to go on with a very successful life. And successful just simply from the point of view of feeling hopeful, feeling that there is a total sense of self-worth and a love that is deserved. Many of the people who've gone through Freedom Store, and I'm sure other facilities of well have come to that place of hopefulness and of being able to move on, being reunited with family, being a part of a community where they can contribute and be an active and social part of a community where they feel whole and they feel valuable and they have a purpose in their life. And I've witnessed that over and over again, where that has in fact been the case. We often get emails, letters, telephone calls. People come back to visit after many years. Got one recently from a gentleman who sent us an email and said, you know, I'm emailing you from Vancouver. I went through Freedom Store 10 years ago. I went through all of the various recognition of the traumas in my life and the healing that I needed, and I sought it and I obtained it and I've moved on. So he felt very in trepidation going back to the community where he experienced so much difficulty. But he said, you know, I came back with a renewed strength and a renewed knowledge of who I am and what I am, and I came back knowing that in fact I could persevere. And he has persevered. And he was just calling to say, I thank you for saving my life. Well, you know, it's not a matter of us saving someone's life. It's a matter of us being available with a listening ear and a hopeful message that with their own courage and with their own sense of, I can do this and I'm worth doing this, that person can then move on and have a good life and a hopeful life. So receiving messages back like that really fills me with that sense of we have an enormous and apparently growing problem with homelessness, with people who are on the street, many of whom have brain injuries, many of whom suffer from mental health issues. And we as a society, and I'm so pleased that with this summit that we're talking about this so much, because we as a society have to take ownership for this problem. We have to share this as our problem and that we are a part of the solution, both with our attitudes, with our actions, with our support, and to really insist that as a community, as one of the wealthiest communities in the history of the world, that we can do more and we can do better, and we are called upon to do better.
Tom, I just have a quick question for you before we move on. You at Freedom Store, you provide sort of a balance of options for your men. If necessary, they take medication. There may be some harm prevention measures. There is the abstinence focus and principles from AA or NA, from what I understand. So maybe you can just share with us that sort of holistic philosophy that you embrace.
Right. We are primarily an abstinence-based facility, but not entirely an abstinence-based facility. And what I mean by that is, for example, if a person is on opioids, one of the current medical modalities is to offer Suboxone as a deterrent to future opioid use and to make that transition from opioid use into abstinence easier and better. And we accept that at Freedom Store as well. In addition, sometimes the attitude is it's either harm reduction or it's abstinence, which personally I don't think it's either this or either that. I think there are various modalities that can work in parallel with one another, and I think both modalities are acceptable and all can be promoted. And I think the key here is, what is the desire of the individual who is struggling with this addiction or mental health issues? What is their desire? Is their desire to walk down the harm reduction avenue wherein, clean needles and safe housing and so on and so forth is available? And if that's their desire, that's awesome, because that should be available as well. If their goal is saying the only way that I can get totally removed from all drugs is to go down an avenue of abstinence, then I think that should be available as well, with all of the medical healing practices that are available to us today in various ways and forms. So I think it's not an either or. I think it's looking at what the individual person struggling would like to try as their way of moving forward.
Yes.
And I think both can work.
Yeah. So what you're saying basically is that every person's situation is unique, so therefore every treatment has to be unique as well.
Needs to be geared to the individual, I think, really.
Yes.
I think in most medical treatment areas, I think the practitioners try to gear the service towards that person, and they say, do you want this service? Do you, if you're suffering from cancer, do you want to try this method or that method or whatever it may be? And I think
Yes.
the same really can and should be true with addiction as well. What does the patient's desire and the type of treatment they feel that will help them?
Great. Well, thanks so much, Tom, and we'll talk again in our panel discussion. Thank you.
Thank you. Pleasure to be here.
So I'd love now to move on to our next mini session, which is called Housing for All, Pioneering a Coordinated, Accessible System of Care. And our first guest on this is Wendy Stevens, and she is a peer operations coordinator with Vancouver Coastal Health. And Wendy has such a powerful story that I'm going to give her the floor to share her own story as an introduction. So welcome, Wendy, and thanks so much for being here.
Thank you. Thank you so much for having me here today. And I really have to say, some of the things I've heard are really quite uplifting and really great to hear people saying, and the things the knowledge that's been shared here today. And I'm very, very grateful to have been invited. So a little bit about me. as Joe said, my name is Wendy Stevens. I am currently the peer operations coordinator with Vancouver Coastal Health Overdose Emergency Response Team. I'm also a person with a lot of lived experience. I spent many years of my life as a drug user. I moved here from Victoria in 1999, so most of my time in my many years of drug use were here in Vancouver in the downtown east side. So as you know, for many years I was an IV drug user. I worked on the street in the sex trade to support my habit. So all the stuff that comes with that. In 2006, I tested positive for HIV, which I pretty much thought was the end of my life. I had recently left the downtown east side and stopped using for a period of time, and I was in the process of getting on methadone, and again, this is back in 2006, so it was a much different process than it is now. And when I went to the doctor to get my prescription, I'd done some blood work previously, and he asked me if I was the type of person who tended to hurt myself when I got bad news, and I said I didn't think so. And he asked me if I was feeling suicidal that day, and I said I don't think that. And then he told me that I had HIV. I don't remember what else he said after that. I was left no support, no knowledge. So I was, I still thought that, HIV was a death sentence. I thought I had just a couple of years to live. So I didn't, I went back downtown and back to using, and I really didn't know anything about meds or anything. So, my way of dealing with things at that time was very much to ignore them and hope that they would go away. It didn't. I still have HIV, well controlled on my meds. So back to my time in my addiction in the downtown east side. Working in a survival sex trade to support a huge heroin habit and cocaine habit as well. It didn't really leave me any time to do things like getting on welfare, getting on social assistance. So much of my time, out there was homeless. So being a woman, in the downtown east side, working in the street, looking back now, I'm in disbelief sometimes at how I survived. At the time, it was really no big thing. It was just my life and how I was living it, and that's how things would be forever. I didn't really know there was a way out. I don't really know if I wanted a way out at that time. So as I was saying, being a woman down there and being homeless, I think back to how vulnerable I was. I would be up for, quite a few days. I'd be falling asleep on my feet, working on the corner, doing drugs. And, I didn't want to sleep outside. I had a phobia. My feet would get bitten by rats. So I didn't want to sleep outside. So, I'd have to find someone's place to crash at. And, still to this day, I can remember the couple or few people whose place I could crash at that was safe. But for the most part, I would be so tired and just desperate to stay somewhere, just to lay my head somewhere, that I put myself in some really, really risky, dangerous situations. I don't know how many times I would go to sleep clothed and I would wake up naked. Naked, very obviously sexually assaulted in my sleep. There were times where I was sold in my sleep. I'd be sleeping at someone's place, and I guess someone else would come to use in the room and see me laying there. And of course, when I've been up for 3 or 4 or 5 days, when I would sleep, it would be a very, very heavy sleep. So a bomb kind of woke me up. So I had these really, really horrific things happen to me in my sleep that, for the most part, I think I'm glad I don't know what they were. So that went on for a pretty long time. I just, you know, like I said, I just couldn't find the time to go get on assistance to get housing. Until one point, I think it was the Carnegie team, they had a sort of an outreach program where for people who were having a hard time accessing services, they could go at like 7 o'clock in the morning, meet an outreach worker from Carnegie. They would take them to the welfare office just a couple blocks away, and a couple of workers would be there early in the morning to fast track people. So I did that. I was housed for a while in one of the Vancouver SROs, and for whatever reason, that just didn't work for me. I for some reason stopped accessing services. So yeah, looking back at that time in my life, and you know, there's a lot of things I'm really grateful for from that part of my life. And you know, all of these years later, as I said, I was a substance user. I've been off of street drugs since 2011. So going on 10 years, I am still on methadone. I've been on methadone since 2006 when I went to the methadone doctor that told me I had HIV. So all these years later, my stable life and all of this, when I go to bed at night, when I turn off the light, one of the first things that comes to my mind is I am so grateful for this bed that I have to sleep in and that I'm safe. All these years later. So housing, giving people housing, it can do so much. But, you know, we see people getting housed. We see people, you know, from the tent cities or the street being housed. And, you know, there's something missing. There's a lack of life skills that people are not empowered with to be able to have a good experience with housing. And it often ends up, as I said, in not a good experience. So, you know, giving people housing, you know, there needs to be life skills taught with that. But part of housing is people who weren't able to be stable on their, for example, methadone or the replacement therapies or ARVs. I was not on ARVs for many years. I wasn't stable enough to be able to adhere to my medication every day. So, you know, that led to a lot of things, such as a lot of opportunistic infections that can come with untreated HIV. Many times I was very sick, many bad infections, pneumonia, endocarditis, all of those things that can come with having a viral load when you're HIV positive. You know, something else about not having housing is, you know, I had nowhere to change clothes. I couldn't have anything because if I had things in a bag, I would lose them. You know, not being able to shower, not being able to bathe, you know, the lack of hygiene and all the stuff that comes with that. Like, there were times I felt bad. I looked bad. It was all really hopeless. And then being super tired and having to go back to one of those risky situations of having to crash at someone's place. It's really a hopeless situation. And something I know now in my life is I didn't realize how hopeless I was until I found hope. And that was through things like, you know, becoming housed back in 2006. And just being able to be stable and have my space, have my own space to myself, to be able to have things, to be able to bathe and shower and, you know, have a toothbrush where I lived and stuff like that. And like I said, you know, having housing and that stability, it can give people the opportunity to make a change if they want to make a change from the substances they're using. For me, at that time in my life, going on methadone, it made it so I didn't have to go through withdrawal anymore. And withdrawal from an opiate, being dope sick, that's another one of those things that really put me in a lot of really risky, dangerous situations of the desperation to get out of withdrawal. So being on methadone was a great relief for that. When I was tired, I could go to bed, whether I had money or for the morning, you know, I I think it's really important to acknowledge that. And as counterintuitive as this might seem to some people, not every person who uses substance wants abstinence. You know, some people aren't ready. Some people might never want to stop using, or some people might just want to change their using habits. And it's really important to give people that that freedom and that safe space to be able to make those choices for themselves. And abstinence-based recovery is such an important option that, you know, is not so easily found. It used to be the only type of recovery there was, and recovery houses was just really abstinence-based recovery. But now, especially with the overdose crisis as it is, it's important to have, you know, many other options for people, whatever treatment or recovery looks like for them. And I also just wanted to quickly touch on something else. We're talking about decriminalization of substances, and I think back to my own time. You know, for quite a fair amount of time, I was in and out of jail all the time. I always had warrants. A lot of my charges were small possession charges. You know, I'd have a little bit of dope, basically just personal my own, and get caught with it and get arrested and charged. So, you know, I was never a big drug dealer or anything like that. You know, sometimes I just sold a little bit here and there just so I wouldn't have to work on the street. But because of that, now I have a criminal record and all the stuff that comes with that, including not being able to cross the border, even though at this time I didn't want to. But it's just my opinion. And stuff like that. So it's really a great time, and hopefully, I mean, we're having this conversation, and this conversation is at city council level, and that will hopefully change. Yeah, I just wanted to say thank you very much, and Joanna is here to cue me that I've talked long enough. Yes, again, thank you so much for listening, and have a great afternoon.
Thank you so much, Wendy, and we look forward to you joining us during the panel discussion. I have some questions for you. And again, at the Fresh Outlook Foundation, we know that the important changes are going to be expedited the more people are exposed to not only the information, but the inspiration. And that is the combination of science and storytelling that I've been talking about over the last 3 sessions. And so Wendy had the storytelling side of the equation absolutely nailed down. And now we're going to hear from John Graham, PhD, who is director of UBC Okanagan School of Social Work. He has held almost $8 million in research funding and published over 120 journal articles, 51 book chapters, and 9 books on topics such as international development, social policy, diversity and social work, spirituality and social work, multicultural social work, and employee well-being in and out of the workplace. John currently heads the Kelowna Homelessness Research Collaborative, an interdisciplinary team of community-based researchers focused on Tier 1 publishing, positive social impacts, student training, and community engagement. So for the science side of the equation, I would like to welcome now John Graham. Thank you, John.
Okay, well, thank you. We've got 15 minutes here, I think, and my purpose here is to summarize the activities of an interdisciplinary group of scholars, principally housed at University of British Columbia, but we have scholars at Okanagan College and with Interior Health as well. If you Google Kelowna Homelessness Research Collaborative, you'll see us, and it's khrc.ok.ubc.ca. And we're a group that was initiated, we actually started to form the day after the Journey Home platform was passed by Kelowna City Council a couple of years ago. And we're sitting on quite a bit of money to conduct homelessness research and basically to support the activities of the Journey Home platform in Kelowna and the activities of reducing homelessness across the Okanagan. We've got 3 areas of research concentration at the moment, and these are based on hundreds of community contact points with thousands of people, part of which included the research into the Journey Home plan, and a good portion of this has continued on with our own community contact points. And our 3 areas in homelessness research to help move the dial towards ending homelessness as quickly as we can are technological innovations, service innovations in human and health services, and representations of people in the homelessness sector, the service users. And these include such issues of stigma, fear, or other aspects. And it can involve public representations, it can involve the experiences of service users themselves, broader members of the public, and so on. From an academic viewpoint, it's a variety of academic disciplines. We're a team of some 12 co-investigators, including me, leading it up. And such academic backgrounds as business administration, data science, engineering, medicine, neuroscience, nursing, various social sciences, including anthropology, geography, and economics, and social work. And we've got undergraduate students, master's and doctoral and postdoctoral students working with us. But most importantly of all, we're a community engaged group of scholars. Anything that we do is collaborative with communities, and our whole point is to move the dial in homelessness. And to do that, one works very carefully with communities and discovers from communities what the research priorities are, and then aligns that with the expertise within our team. We're part of the Center for Excellence, the Homelessness Observatory, housed at York University, which I helped to co-found over 10 years ago with Steve Gates, and we're involved with a number of different consortia of homelessness scholars across the country. Now, in terms of the technological innovations, those largely involve engineers and business administration faculty, as well as some social scientists and a couple of social work scholars. We're taking a look at various technological innovations, including phone apps that are not uncommon in the homelessness sector for service users to help assist the transition from homelessness to housed. We've got a personal carrier that some of the engineers designed as a proxy for an improved shop cart, and we're analyzing the social impacts of that in 2021. The second area of research, service innovations in the human and health services sectors. We've got our neuroscientists working with fetal alcohol spectrum disorder scholars in the areas of protocols for working with service users in the sector. There needs to be a greater sense of rigor in identifying various issues that Wendy and others have, the previous presenter Wendy and others have elaborated in the actual experiences of homelessness, various mental health issues, substance misuse issues, the various neurological issues such as traumatic brain injury or fetal alcohol spectrum disorder or other sorts of things. And so we have internationally renowned scientists that are helping service providers to assess those risk factors and those incidences in order that service provision could maximize the efficacy of services and really help to get people moved from homeless to housed and to help to provide the most appropriate services for various individuals. We've got a large grant that is comparing the experiences of service providers once a given multi-year plan to end homelessness is launched. And we're doing a multi-city comparison of Kelowna, Sherbrooke, Quebec, and Lethbridge, comparing the similarities and differences and discovering where service providers are doing very well in adapting various protocols associated with multi-year plans, including databases that are often new, such as HIFIS. We're identifying those things that are going well and we're scaling them on. Here in Kelowna and other parts of our community, we're working very closely with municipal authorities in Vernon as well. We're holding continuous community forums. In a pre-COVID environment, we were holding those quite frequently at the downtown library in Kelowna, involving service users, members of the community, neighbors, service providers, business people. We've got scholars that are taking a look at media and social media representations of homelessness within our community. I'll give you a flavor of some of the projects that are on the go right now as I speak. We've got several graduate students that are taking a look at multi-year plans across Canada. Kelowna has launched one. Vernon has a background in one and is interested in obtaining increased funding for a possible further moving of the dial in that area. And so the question is, what are the commonalities and differences amongst these various homelessness plans? Which ones emphasize housing first as a priority, for instance, and how do they do so? Those sorts of questions. Nobody's looked at those sorts of things before. Nobody's taken a look at homelessness plans of cities of the scale of Kelowna or Vernon in a deep, systematic way as we're doing. We're taking a look at the lived experiences of various service users who were transitioned from housed, but are now finding themselves back to shelters. We're discovering the subjective experiences of those sorts of individuals, and we're trying to determine what may maximize the possibility of their staying housed on an ongoing basis. The personal carrier initiative I mentioned earlier, and it's a very innovative design that includes capacity for charging cell phones from the sun. It moves with relative ease. It's an extremely important project, and we're very interested in understanding the impacts on service users, service providers, but also broader members of the community, including businesses and neighbors. We're doing a literature review on safe injection sites to let various service providers and members of the public understand what the evidence is actually saying around safe injection sites in terms of social science and health scholarship. We did this summer a major study involving the experiences of service providers in light of COVID and what might be some of the things that are innovative and helpful in service provision. And we rapidly collected that data and rapidly distributed it in easy to consume format to our service provider partners. And we're working on other projects as they evolve, various secondary literature reviews and all the like. And once COVID lifts, there'll be a further scaling up, and I anticipate major public forums where we grapple with the issue of homelessness and engage in community embedded, community inputted solutions to the very wicked problem of homelessness. So that would be our activities in summary. And I'm happy to field questions or to take this however it might be useful to the group.
An example of what academia brings to the mix or brings to the table, so that we can all discuss how to expedite these solutions. So what I'd like to do now is bring all of our speakers back in for a panel discussion. We have about half an hour, so I think we should be able to get some good conversations going here. First of all, John, I have a question for you. I know that you have been working with the City of Kelowna on the Journey Home strategy. Can you tell us about that level of collaboration and how important it is?
Well, it's really important because, I mean, we've got considerable expertise at the university, really skilled researchers, really skilled students. And there's a lot of that capacity that could be brought in the real world to help move the dial as quickly as possible. The Journey Home platform itself, I think it's a very good plan. It makes a lot of sense in emphasizing the 15% of chronically and ongoingly homeless people and really concentrating on that particular population first and foremost. I think that's a very sensible way of proceeding. So the plan itself is written by a former student of mine, of whom I'm most proud, Lena Turner, and it's very much informed by the social science evidence around homelessness with the emphasis on housing first. So that whole framework of research embedded ways of understanding are important, and they would influence any municipal jurisdiction, including Kelowna.
Fabulous. So, Lawrence, I'd like to bring you into the conversation. You've been listening to all of these presentations. Do you have a question that we can get going with on this panel?
I mean, thank you, first of all, to all the presenters. Fantastic material, so insightful. And again, I feel vastly underqualified to be sitting here chatting with you. But I will say that from my experience of, a decade and a half of frontline work with this community, and sadly, obviously in the last number of years with the opioid crisis, having buried in excess of 70 members of the community myself, people who I knew well, there's a level of urgency that myself and I know many of you share in terms of solutions. And I think, I don't have this question particularly for any one individual, but I would say, where do you see some of the areas for improvement in terms of integration around seeking solutions?
I should say, Lawrence, that you're quite qualified. I mean, with your considerable experience, it's very important. And the solutions actually do reside in the locally embedded machinations of the community. And the solutions stick when there's genuine community engagement and community commitment. And that simply involves people. It involves neighbors. It involves businesses. It involves political actors. It involves all of us within a community. In order to reduce those risk factors and to attend to things. I mean, the sheer example of opening the Foundry several years ago to treat quickly various mental health issues amongst youth is an example of a homelessness reduction strategy, reducing the probability of homelessness within a certain population, reducing risks. But it has to be kind of coordinated, because it's not just one thing, as we've been saying all day. It's multiple factors: substance misuse, mental health, poverty, traumatic brain injury. It's at the macro level in terms of insufficient housing stock and the sky-high levels of rents and so on. And it's at the micro level of individual risk factors that could lead somebody from tipping to a risk of homelessness to actually being homeless. And sometimes it just takes one individual to assist somebody and to reduce that risk in that individual's life. So it can come down to every one of us within a community doing what they need to do to attend to their neighbors and their friends and the people around them.
Stephanie.
Anyway, maybe I'll just pick up a little bit on some of what John said about, how it can start with each one of us. And I think that that's a really important point, that these are very, very complex problems, but at the level of the individual, if we again start from that place of compassion and shared humanity, and that one person reaching out to give a little bit of assistance can go a long way to start to change those lives and having those conversations. So I just keep coming back to that kind of real local level of just one heart, one mind at a time, and we build from there.
Great. Tom, you had something to share.
Yeah, one of the things that seems to me that's a major problem, and I'm assuming that we would all agree to it, is the immediate availability of service. When a person presents at the hospital, for example, and says, I'm ill, I'm sick, I need help, I need it right now, is there that immediate availability of service? And if there is, and the service is then provided to them, where do they then go when they're leaving the hospital? What do they go to? Do they just go back to the street? Or do they need to go to a detox center? Or do they need to go to a recovery home? Or do they need to go to safe housing? In other words, where is their bed? Seems to be an enormous part of the problem here. And probably the largest missing link is that when a person needs the help and wants to get off the street and wants to have some change in a life, where does one go? Where is the bed? it's a major problem. And I think we as a society should be able to afford more immediate beds available.
Yeah, if I can chip in there, I mean, I think I think it matters what you call a bed. I don't think that the province needs more treatment beds. If somebody comes into the hospital with an acute illness and that illness is taken care of and their addiction is, you know, is underneath it. My, you know, clinical experience is often that's not the time to get people directly into, you know, into a bed. I mean, certainly, if people they need to do better than go back to the street or their home, like we can deal with those social problems. But I think for many people, timing is everything. I agree, but it's really you know, a long process people have to commit to, and if they're in acute trouble, often they admit to they'll agree to doing anything, and I've just seen so many people be shipped off to a detox, and it just crumbles very quickly. When we were there was a program in Vancouver in the downtown east side. They set up a special unit, like they brought in a big truck there, and everybody who overdosed was brought to this truck and immediately put on methadone or Suboxone or hooked up with a physician right away. And the connection with that physician at like a week was like 5%. I mean, so this idea that, you know, we need to, you know, jump on people when they say and get them into a bed or like in the long term, I don't think that's really going to make that much difference. And you know, I do think that, you know, having been, you know, working in hospitals for 30 years and seeing people shipped back out on the street, clearly that's not the idea either. But I don't think it's the time when you know, dig your addiction clause into people and say, now's the time you're going to change, because I just don't see that. And yeah, so, and I mean, I think one of the interesting things to discuss, and you know, being a clinician and seeing people's lives improve because they get proper medical care, I certainly see this, you know, one person at a time, one heart at a time, if we can really work with somebody. But I just think we've created the structural damage that just, you know, we have to think of this more in terms of public health. Like what can we offer people as a community? And this isn't going to be fixed one person at a time, at least in any kind of reasonable time frame. Like, and that's what we've seen for, you know, 5 years of the overdose disaster. Just the numbers are just keep on coming. And I'm sure during that time, many of us have seen individuals get into recovery or do much better. But until we look at this as a public health crisis and the poison drug supply and the criminalization and the housing problem and all these things need sort of a public health approach to changing it, I think if we want to see anything happen in any reasonable time frame.
So I'd like to just bring up something that Tom told me when we first met about this, and it has to do with the people being stigmatized by healthcare workers. And I know that Stephanie, that's an area where you have an area of expertise and would love to hear from you. But Tom, explain to me what has happened to you when you've taken some of your clients into the hospital for care for something unrelated to their former substance use.
Well, I'm going to start. I'm going to start my comment or my answer to that is by saying that so often when going into the hospital, there have been extremely caring and concerned and helpful, positive people who have been available. Unfortunately, there were also circumstances where, and I'll use Abe as an example because I told my story of Abe, you know, an actual person. And he, one day when I was with him, was in, he'd been clean of alcohol and drugs for a year at that point, but he was in a great deal of distress, a great deal of anxiety. He was in need of some mental health help immediately because he was in such a stressful way. So I went down to the hospital with him and I explained, this is Abe and he needs some help right now, and he's just going through such a stressful day that he needs some assistance. So a psychiatric nurse was brought down and we were in a room and we were explaining what was going on. And the end result was, the answer was, I don't think you need any help. I think you should go back to the gospel mission. And I was stunned, and I said, I'm sorry, I don't understand what you're saying. He's never been in the gospel mission. Why are you using those words, and what are you saying to me and to Abe? And she said, oh, well, whatever, he can't stay here. He'll have to go because he doesn't really need help. And I just was left with, when a person who has a brain injury and other mental health issues can go into the hospital and be told, we can't help you, you need to go back to the gospel mission, I'm left dumbfounded by that. And clearly, I'm not trying to say that's the answer that people get every time, but I now have taken enough people down for assistance and have had that kind of an attitude come back. At the same time, there have been so many that have been so helpful. So I think you can't label, I think it's wrong to label anybody, any group, anything, and have it stick, because that's totally inappropriate. In exactly the same way as you never label people who are suffering from addictions in one way and stigmatize them in that way as well. So my point being, these people need help. Are we as a society going to make it available to them?
So before we get to Stephanie, Wendy, can you share any stories? Have you had experience of being stigmatized by healthcare workers?
Yeah. Yeah, that's so sad that happened to A, because there is so much stigma about, around people who use substances and the worthiness of care. And I'll quickly share a story of my own. When I was still in my addiction, I had a bad infection. I had an abscess on my arm. I was really sick. I needed to go to the hospital. I needed IV antibiotics. I didn't want to go. One of the hospitals here in Vancouver has a very bad reputation for its treatment of people who use substances, especially from the downtown east side. So I didn't want to go. I I knew I wasn't going to get anything for pain, much less withdrawal. So I kept making the excuse, okay, I'll go as soon as I make enough money to take some heroin with me, so I won't have to ask them. Finally, I did that, and just stalled. Finally, the staff at Insight, the supervised injection site here, they had enough of that. They put a collection of money together, gave it to me to get enough heroin to take with me. Put me in a cabin, set in the car. So that's fine. I was in a lot of pain. I was really sick. I was in a really bad place. So when I got there, they obviously weren't happy seeing me, someone like me. So I was in one of the little curtained little rooms there, and I was crying. I was in a lot of pain, and the doctor came in and he had an intern with him, and he just looked at me and he kind of rolled his eyes and he said, if you think this is unpleasant for you, how do you think we feel having to see people like you every day? So that didn't feel that good. So anyways, he examined my arm and he was really quite rough with it. And he decided he needed to drain it. So he left and came back. And again, he's still been really rough with it. He said, okay, you're going to feel some pressure. So I kind of looked away, but out of the corner of my eye, I saw him, grab my arm, and he just wound up and stabbed it with freezing. And I cried out because it hurt. And he leaned over and he said, if you don't shut up right now, I'm not giving you any information. And I remember the look on the intern's face that he had with him was so embarrassed and just really shocked at this. So yeah, I don't remember much more from that time in the hospital, but yeah, that's just one story from one person, and there's so many. stories of why people don't get health care and, the outcomes on people's health and on their lives because of the reluctance to go and seek health care, when they really, really need it.
So, Stephanie, what does your work say about this?
Well, I think, it certainly is consistent with both what Tom and Wendy were saying and their stories. But what we also, what comes up a lot is that, it's the positive and the negative together. And many healthcare providers, we've heard them tell stories of the fact that they realize they're treating people in ways that are not correct, and they don't like how they feel. They realize they're doing these things and they don't like it. And what they say is, it's kind of this recognition that they're also working in traumatized systems and traumatized environments, and they are highly constrained in many ways. They recognize the structural stigma, they recognize the barriers. And so it's almost, in some cases, a reaction to, we don't know what to do. We don't know what to do with folks when they walk through the door. And it almost becomes a bit of a knee-jerk reaction. And it's exacerbated when, they're coming to the end of a long shift, or they're feeling burnt out, or they're feeling overwhelmed. So we've got this problem of provider trauma as well, and provider burnout. So we kind of have to work on it from that end as well. And I think that's a really big piece of the puzzle, or just, kind of a really big thing that we have to keep in mind as we talk about this problem of stigma in the context of the health. Yeah.
Mark, do you have a comment about that?
Sure. I think that the hospitals do quite a poor job, but part of that is because we're trying to, fit a square peg into a round hole. So hospitals run on routines, and everything is, double checked, and the patients who are in the hospital are expected to follow those rules exactly. So you take people that are not really interested and don't feel they need to follow those rules, and there's really no wiggle room in that system. So it's really, when I worked on the 10C ward for about 12 years at St. Paul's, which was 20 beds of people with drug use and medical problems, I was always fighting against the hospital for putting in crazy routines. Like, they closed down the smoking room on the 10C, or the smoke. Like, I guess smoking's not very good for people, but that really puts 20 people in a very bad way. And so we're going to get people leaving hospital because they can't get a cigarette. And sure enough, that's the biggest reason people leave. So the hospital system, just an example, is totally inflexible. And you're expected to follow rules and do exactly what the protocols say. It's run by people, mostly nurses, are on unions. They're very concerned about employee safety and protocols. And, I'm not arguing that's not a good idea, but they're not set. The system isn't set up. We need alternative systems for people, and alternative setups. I helped set up the program in the downtown east side, where there's 6 beds and people can get their IV antibiotics there, and they can come and go as they please. And that keeps people to finish their medications, where none of them were finishing their 6 or 8 weeks in hospital. So we need to be much more imaginative about how we can help people, and meet the needs of those people, the people that, need it, and just don't fit into those kind of rigid hospital environments. And we need to make different. It'd be easy to make accommodation. And that other, a great example was the downtown community clinic, and I started working there in 1999. And it was on Powell, and it was a bit of a madhouse. So there was a lot of stuff going on. People were acting out. Some days there were fights. Like, it was a difficult place to work, but people came. Like, it was packed. So we saw a lot of people. And then Vancouver Coastal Health moved a brand new facility. But the first day there, somebody threw water at one of the receptionists the next day, big plexiglass comes up. There's a guy with a paladin jacket at the front door. They put up gates. I mean, I it's a bad thing that that person got water thrown at them, but these things are going to happen. So then the clinic for the next year, attendance was about a quarter. Like so we make these structures to think we're helping people, but we build in things that are just chase people away. And so the healthcare system is messed up. Not so much of the individual bad actors, but just the whole the whole system that we've set up that is not accommodating to people with different needs.
Joe, do you mind if I jump in here for a quick second?
Please do.
I want to just say too, I think just from my experience, I would say that, and I think it was Stephanie who touched on this earlier, but when we talk about the assumptions, I think sometimes that go with stigma is one of the ones that doesn't get transmitted very well in terms of education and advocacy is the sort of the fear and the mistrust of institutional power. And there's an element to which even just the edifice of walking into an organization or an institution that looks like you don't belong there, that looks like there's power and you don't have it. And hospitals are one of those places. And I think that so often I would get a phone call that somebody I was working with or supporting in some way was in the hospital, and I would literally hightail it down to the hospital, not because I was concerned about their safety or that they weren't going to get the right proper medical care, but because I knew that they had this deep mistrust of the institution, and that would translate in some kind of episode. They would start acting up and it would be misunderstood, and I wanted to be there as an advocate. And there was a particular incident where I was actually in the emergency unit with 6 different people who all showed up randomly, who I happened to be working with on one night. And I was advocating for all of them at the same time. And I think one of the pieces that does work, one of the success stories that does work is when established organizations, be it mental health agencies, health authorities, medical services, when they start to work with community. I think John spoke to this a little bit, this whole, because I was involved in granted a very unusual church, but like a church that had postured itself, almost aligned itself as a social agency, that there are remarkable resources in terms of bringing alongside and equipping other organizations to work with you to help minimize or lessen some of the intensity of that workload. I mean, there's a lot of social workers, caseworkers who just simply cannot do what I was talking about, which is to hop in a car and rip down to the hospital at any given moment, because they don't, especially in the evenings, 4 p.m. comes by and who's going to be there? A lot of these, as Wendy will tell you, and anyone with lived experience, a lot of these crisis moments, especially when you're engaging with health authorities or enforcement, always seem to happen at night. And so if you don't have the capacity to deal with these at night, that's another glaring gap in the service provision.
If I can just jump off one more quick comment about that, like the hospital situation for the way we treat people is one thing to focus on, but just the whole general approach to people who are maybe not having an acute health problem right now, but using drugs every day. We tend to be, people need autonomy and some sort of control. And so the MySafe machine that I'm giving drugs out of, the biggest reason that it's working is people can do it on their own terms, and they can go in, and we think that it's so valuable to have a pharmacist watch people drink their methadone. Well, maybe the first couple of days, but every day, people do not need or want that sort of attention. Like they in Insight, I spent so much time there. 95% of people go in there with their heads down, use their drugs, and leave. Now, there's lots of friendly people around who could talk to them and help them. And so 5% of the time that happens, but most people don't get up in the morning looking for somebody to help them. They want some autonomy. And so to go to a machine, get their drugs, and just leave, is way different than going to a pharmacy, having to interact with somebody, no matter, even if they're the nicest pharmacist in the world. I mean, it just doesn't need to happen every day. And it just reminds people of, you know, what they're doing. And people have enough trouble with self-esteem. And just to say to somebody, look, I'll register for this. You pick it up when you want. You're on your own. Let me know if you have trouble. I mean, that to me works so much better for most people, rather than trying to, you know, just overwhelm them with your love and interest. And you know, we all know that people will, you know, change or reduce their drug use or when they're ready. And we're not the best judges. You need to be around, but I'm really learning that autonomy and giving people some sort of recognition that what they're doing is maybe not the greatest, but that's what you decided to do for today. Let's make it as safe as possible, and I'll see you tomorrow. Is my approach now. So.
Well, two things that I would like to ask before we close off. One is about stigma that occurs at the individual level toward other individuals. So one thing that we talked about, Stephanie, in our podcast about stigma is how every one of us has biases that we either are aware of or aren't aware of. And how important it is for us at an individual level to try and get in touch with those biases and how we may be affecting other people because of them. So can you, Stephanie, first elaborate on that and how important that is and how we can do that?
Sure, thank you. I think you've framed it really well, and I think I talked about it a little bit in the presentation earlier, where, you know, there's a number of you know, biases we have that can be very explicit, right? Where we clearly, you know, have negative attitudes towards certain groups of people. But a lot of where stigma comes from can be implicit, you know, where we think we're doing well and we're thinking well, but then, you know, you know, we realize, you know, often through a confrontation or an interaction that maybe we are carrying other prejudices or stereotypes.
Any other comments about that? Wendy?
That's very interesting. Many years ago, when I first started as an outreach worker in HIV, my boss gave me a assignment, and we were talking about judgment. And, you know, some people will, I don't know how many times I've heard people say, I'm the least judgmental person in the world, and there's no one less judgmental than me. And I judge them. I'm joking, but not really. So what I did is, I think I had an appointment at BC Women's Hospital or something. So I had this in my mind about judging people, and I really didn't think I was very judgmental. So I remember I was walking, and I caught myself looking at people and judging them, and, you know, doctor and judging the doctor, and, you know, homeless person and judging. So what I did was I rolled up a paper, and every time I caught myself judging someone, I'd bonk myself on the head. I probably look ridiculous, and it's a miracle I didn't get a concussion. But it was really an eye opener, you know, just having that time of being aware, being self-aware of that behavior in myself. And this was quite a few years. This is probably 10 years ago, and I still think about it now. I don't hit myself in the head with a newspaper. It it was an eye opener about, you know, my own biases and judgments.
Okay, my last question is about collaboration. And at FOF, we are all about communication and collaboration. This whole summit has been about communication and about using the community-based social marketing model of educating people, engaging them emotionally through storytelling, and then talking about opportunities for positive change. And so I want to take Jacob's research. We're talking about the pure research that Jacob is doing with regard to the link between traumatic brain injury and homelessness. So there is something that we can actually chew on. We can actually take that and take a huge bite out of it and then work together to find some solutions based on what Jacob has found. So what I'd love each and every one of you to do is just take a minute to talk about collaborating using Jacob's research and what he's learned about the links between TBI and homelessness, and how can we collaborate to make that meaningful and productive information? Because I truly believe that research is only as good as how it can be applied on the ground for positive change. So who'd like to start with that?
Yeah, part of it would be knowledge mobilization and just getting the word out in accessible manner to the varieties of professions and the varieties of service providers that are involved in the homelessness sector and beyond it, because it's a very intersecting thing.
Mm-hmm. Well, and I've noticed that in the 30 years I've been doing this work is that academia now is much, much better at engaging with the public and sharing all of that information. So that's a really great step in the right direction.
I can just add on to that. That's very true. Knowledge mobilization, and I would add on to that in the context of the education piece that I was speaking to before in the stigma reduction context. That applying Jacob's learnings and that kind of research to help shift our understanding. You know, again, it's just another piece that contextualizes and helps us make sense of substance use and addiction and homelessness and the interconnections and some of those, you know, those determinants and those influential factors.
So Tom, you were the person who turned me on to Jacob's research. How are you going to be using that information in your program?
Well, I think understanding every bit of information that you receive that you can then apply to an individual on a day-to-day basis clearly is helpful. And when one understands that a brain injury results can have a direct correlation to homelessness, can have a direct correlation to addiction, etc., enables us to add that one more tool into the arsenal of saying, what are the issues that you have suffered from? What are your traumas? What are the do you have brain injuries? Do you have mental health issues, et cetera, et cetera? Because part of our job is not only to work within Freedom Store itself, within our own boundaries, with our own resources, but it's also critical to have for us to get these people connected with the various resources in the community, which is what we do. But it's also very important to know that this issue of a brain injury is so vitally important when it comes to the person then leaving us, moving on, and then ending up right back in the street again because of a brain injury. In other words, we need to link people directly into the services that they need, which unfortunately is all too often not enough services. But knowing what the person suffers from helps us to link them into the community services available for that particular issue, that particular problem. And I think the sharing of this knowledge is vital. There's another one, if I may throw it in, and that is there was a study several years ago by the Canadian Mental Health Association that said of our young people, that's middle school, high school people, 20% of them are suffering from mental health and or addiction issues. And of that 20%, only 25% of them are actually getting any help. So if we take an example of all over BC, all over Canada, we have a classroom with 30 students in it. And if 6 or 7 of them are directly struggling from mental health and or addiction issues in middle school, high school, and 4 out of those 6 are getting no help, no services whatsoever. Don't we need to know that? Don't the teachers need to know that? And who is there to link those 4 when they're 12, 13, 14, 15 into the services that are needed so they don't land up on the street, so they don't end up in prostitution, so they don't end up in severe drug addiction and in fact street life, as are dealing with our children as we should. Let's get the help to them early enough to avoid more and more and more traumas later in life.
So Mark, Jacob.
Can I just hop in too as well? I just wanted to clarify one thing. I'm very much a research trainee. I'm not an independent scientist. I'm a PhD student in the part of a very large team. So I just wanted to clarify that. But also in the work that I've been a part of, there are things that there are people that I've met that have had aggression and or they're labeled non-compliant after a brain injury. But also there's stuff that's simple enough as forgetfulness, and cognitive impairment and sort of forgetfulness after brain injury is one of the most common things that we're sort of seeing in the research. I think that trying to just synthesize things a little bit is education for frontline workers, healthcare workers on, maybe they're non-compliant because of a brain injury, but also just having supports available for things like reminders for appointments. We have so many of our participants that have real challenges just remembering to pick up a prescription and that sort of thing. And it's certainly not all attributable to brain injury, but supports, and this is what I thought was great from Dr. Tindall, was support if they ask. That's one thing that I've really taken away too from my work at OPS and with our study, is having the supports available, but not foisting it upon someone, having it available if they ask.
So Jacob, do you have a vision for how your findings could be used to the greatest advantage?
That's a really tricky question because, I think this is the natural question, but I always have to give very unsatisfying answers, I think. Partially, brain injury is just so complex. There are so many long-term, medium, long-term challenges that you can have from a brain injury. There are no great treatment solutions. So I think education and support are my main takeaways, but this also very much depends on what we find in the next little while. We are sort of looking into some things like increased psychotic symptoms after brain injury. And so in the future, what I'm hoping for is that if we are finding that sort of thing, that could lend credence to frontline workers should be perhaps screening for traumatic brain injury. That might allow triage to better services. Things like just increased monitoring. Like if people want it, you've had a brain injury, maybe you're at risk for more psychotic symptoms, maybe we'll check in with you more frequently. Maybe we'll help you remember to pick up your prescriptions if you want it. Mm-hmm. Or in the future, it could be something all the way up to like prophylactic, as in before something happens, increase of antipsychotic medications. But this is all, again, speculation, just because it's a very muddled scientific landscape right now, and it's stuff that we are certainly working on.
Mark.
But the work that Jacob and Dr. Donkler and others are doing is very important for training professionals such as social workers, nurses, psychologists, physicians, and other sorts of people that are immediately heading into the community. And so Jacob's stuff and others like him, terribly important there. And Jacob's point about simply introducing a protocol within a social service organization so that they can start to assess for TBI, I think is a huge gain right there, because the workers can start to know the etiology is something. They can start to know that there might be, something associated with this, and there's a greater sense of clarity. And we need a lot more in so many different areas of those protocols that are accessible for frontline workers to use.
Mark, you had a comment.
Well, just I mean, I think Jacob said that it really helps with the empathy part of things to try to understand where people are coming from is very, very useful. I just, this is going to be an increasingly bad issue because of the overdose crisis. So people have to realize that for everybody that dies of an overdose, there's 20 that don't. And being hypoxic over and over is not good for your brain either. So I think we haven't begun to really investigate the damage this is doing to the community, even those people who survive. And to try, I'm afraid to even suggest that we start measuring that, because I think we're going to find things we don't really want to find, and we'll just compound the high level of existing pathology.
Well, thank you all. You have been just amazing. And thanks to all of you viewers out there for staying with us to the end. We're just about ready to sign off. But before we go, Lawrence, given what you've heard today, can you highlight what you think are the most promising ways you've heard of to integrate solutions for substance use and homelessness?
Well, just very quickly then to say, thank you to all the presenters. Just powerful, impactful stuff, and to all of you who've been watching as well. I think, Joe, one of the things that just stood out, even from that panel session right at the end there, is that integrated solutions can lead to very practical protocols that can help people on the front line of the work they're doing. And the other really kind of, I thought, pragmatic but also profound kind of, it came through a number of different presenters, but Jacob touched on it there at the end. We have to respect the agency of people's humanity. And so, we can offer things if people want that. So it's twofold. I think is what can we do in an integrated fashion to offer protocols, screening tools, greater awareness for agencies and professionals working on the front line with the vulnerable population. But equally then for in terms of not just advocacy, but also in terms of respecting the agency of people's humanity, that has to be held kind of delicately together.
Thank you, Lawrence. Well, we've come to the end of our summit. We've been here for a day and a half, and I cannot tell you how much this has meant to me personally, not only as founder of the Fresh Outlook Foundation, but also as a community outreach and engagement specialist. What I've learned will really help me moving forward. I have been informed by the science. I have been inspired by the stories, and I have been totally recharged in my commitment to move forward with Heads Up for future summits and for our Heads Up Community Mental Health podcast. So please check that out on our website. We've got some amazing discussions up there already, and we'll be uploading many more in the next few weeks. And so again, thank you to everyone for just making this such a great experience. Let's bring the walls down and let our hearts in with a promise of action for positive change.